Thank you for getting us started. Good morning. I'm Virginia, or Ginny Bucola. I'm the chair of the DUR Board and P&T Committee, and we're going to convene the DUR Board for today, August 18th. We're using Teams, and I know I'm not fluent in Teams, so thanks for everybody's patience with button pressing and things like that. I'm going to read off the names of the participating attendees, and if you could please unmute and say here when I call your name. I'll start with Alex Park.
Good morning, President.
Good morning. And Diane Schwilke. I think Diane's not here yet. I'll go to Jordan Storhaug.
I'm here.
And Nancy Lee.
Here.
And Leah Marcotte.
Here.
And Susan Flatabeau.
Here.
Catherine Brown.
Here.
Kavita Chawla.
Here.
Michael Corsiles.
Here.
Thanks, committee members, and good morning to you. The Healthcare Authority members with Lita Vasquez.
Here.
And Donna Sullivan.
I'm here.
Ryan Pistoresi.
Here.
Luke Dearden. Moving to Ryan Takatomo.
Here.
And Marissa Tabile.
Here.
Amy Irwin. And I'll move to our Magellan Medicaid Administration member, Umang Patel.
Here.
And our Managed Care Organization representatives, Greg Seamus with Molina. Moving to Heidi Goodrich with Molina. Going to Petra Eichelsdorfer with United Healthcare. Going to Omar Daoud of Community Health Plan of Washington. And going to Jeffrey Natividad with Community Health Plan of Washington. Okay, good morning to everyone. I'm glad you're here. I'll let Lita go over the meeting logistics.
Okay, there's Diane. Okay. Diane, can you unmute yourself? Okay, all right, I think you're on. Did you call in from a phone?
I did, yes.
Okay, do you want to use that phone? We can switch that over to presenter.
I'll be using this for the meeting, yes.
Okay, so it seems to be working. Okay. Okay, just going over the rules for today. Thank you for being patient. We're using Teams for the first time, and we have to move everybody over to presenter who's going to be speaking. And presenters can mute and unmute themselves, so please mute yourself when you're not speaking to limit the background noise. Please share your webcam while you're presenting or for the committee while you're deliberating. The meeting is being recorded, so please state your name each time that you speak. For stakeholder participation, the chair will first read the list of stakeholder names who pre-registered to speak, and I will unmute you after your name is called. You'll have 3 minutes to speak. After, the chair will ask if there's any other stakeholders. You can use the raise hand function and I can unmute you. You can also use the chat function to enter questions and we'll address those during the stakeholder time. Let's see. Yeah, I think that is it. Thank you for your patience in this, yet again, a new platform. And so I will share my screen now for Umang's presentation.
Great, thanks, Lita. So our first presentation by Umang is on antipsychotics and anti-manic agents. And this is Virginia. Just a note for the committee, this is going to be one presentation and then it'll be broken into 2 separate motions for us to consider after we hear Umang and the stakeholders. Thanks.
This is Umang Patel. Thank you very much. We'll go ahead and get started with the antipsychotic, anti-manic agents. Just a reminder to the committee, what we've primarily done in the past is we highlight significant clinical updates That being said, if there are any guidelines or anything pertinent that's over a year old, I generally do not go over it, but I do my best to put it in the appendix so the committee can refer back to that if they would like. And we'll just go on to slide 3, Lita, if that's possible. And then in this antipsychotics class, you may, again, just a refresher, sometimes the classes that Magellan has and the classes in the Apple Health PDL aren't always one-to-one. The top title for antipsychotics is the Magellan class. The 3 subgroups are the specific lists, class names in the Apple Health PDL. And so this will encompass second-generation antipsychotics, combinations, and Parkinson's psychotic disorder as well. So on the next slide here, to go over the disease state and descriptions, schizophrenia is the most common psychotic illness, which affects 1% of the population. Between 25 and 50% of schizophrenic patients attempt suicide, and 10% of patients succeed in their attempt. Symptoms include delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, negative symptoms, and at least one of these should be delusions, hallucinations, or disorganized speech. Again, the guidelines are roughly 8 years old, so we will not be going over them. Since this practice parameter is over 5 years old, it is considered to be a historical practice parameter. However, newer guidelines guidance is not available from the AACAP. On the next slide here, according to the American Psychiatric Association just last year, they had released guidelines stating since schizophrenia is a chronic illness that afflicts all aspects of life, the goal of treatment is to stabilize the patient, which is defined as reducing acute symptoms, to return to baseline functioning, prevent recurrence of symptoms, and maximize functioning and quality of life. Goals may also be based on individual patient preference, impacting school, employment, and other quality of life impacting components. The guidelines recommend that patients with schizophrenia be treated with an antipsychotic, including monitoring for both safety and efficacy. An antipsychotic should be continued in patients whose symptoms improved, and the APA suggests that the same antipsychotic be used. They recommend clozapine specifically be used in patients with treatment-resistant schizophrenia and in patients with significant risk of suicide. And they also suggest clozapine for patients with aggressive behavior despite other treatments. A long-acting injectable is suggested for patients who prefer this therapy or for patients with a history of uncertain or poor adherence. Notably, the guidelines state that an evidence-based ranking or algorithm approach for antipsychotic selection is not practical due to clinical trial heterogeneity and limited comparative trials. In addition, there's no preference for first-generation antipsychotics or second-generation antipsychotics, although clinical meaningful distinctions such as tolerability do occur. With the exception of clozapine, no antipsychotic has demonstrated superior efficacy when compared to other agents in the class. They also state that there is no reliable strategy to predict response, thus, initial treatment choice is often individualized and includes several patient-specific factors. And lastly, the guidelines also detail management of adverse effects such as acute dystonia, Parkinsonism, akathisia, and tardive dyskinesia, some of which may warrant a switch to an alternate antipsychotic treatment. Moving over to bipolar disorder, this is a lifelong prevalent, for bipolar disorder, lifelong prevalence estimates a range from 0.9 to 2.1% of the population. It's characterized by episodes of mania, depressed, or a mixed state. Criterion used to diagnose bipolar 1 disorder is the presence of a manic episode, defined as persistent, elevated, expansive, or irritable mood for at least 1 week with increased energy and activity, or mixed features specifier, which is rapidly alternating polarity of mood through sadness, irritability, and mania for at least 1 week, and 3 or more other characteristic symptoms. These symptoms include there's a litany here, but self-esteem, inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual or pressured speech, flight of idea or feelings of racing of thoughts, distractibility, increase in goal-directed activity or psychomotor agitation, and excessive involvement in risky, pleasurable events. Again, the guidelines are almost 20 years old, however, they're here just for reference. Moving over to Tourette's disorder. The The prevalence of Tourette's disorder is unknown, but observational studies have suggested about 1% in school-age children. It's a genetic tic disorder characterized by motor and vocal tics. Generally, individuals have repetitive stereotype movement of vocalization, which could involve sniffling, muscle tension, or blinking. The DSM-5 criteria for Tourette's states multiple motor and at least one vocal tic being present during the illness, not necessarily simultaneously, and have been present for 1 year or greater, although they may wax and wane in frequency. Onset of these symptoms must occur prior to 18 years of age to be considered Tourette's. The peak severity typically occurs between ages 10 and 12 years of age. And tics usually improve during adolescence, with 18% of those older than 16 years experiencing no tics and 60% having minimal or mild tics 6 years after initial examination. And we have the AAN guidelines from about 2 years ago regarding Tourette's as well. All right, moving over to the next slide, we will go over our first clinically updated medication. We have a new medication here, Lybalvi. In June 2021, the FDA approved this combination medication of an atypical antipsychotic and an opioid antagonist indicated for the treatment of, and it has two here, schizophrenia in adults and bipolar 1 disorder in adults for acute treatment of manic or mixed episodes as monotherapy and as an adjunct to lithium or valproate and maintenance monotherapy treatment. This new medication does come with black box warnings here. Elderly patients with dementia-related psychoses treated with antipsychotic drugs are at an increased risk of death, and Lybalvi is not approved for the treatment of patients with dementia-related psychosis. There are additional warnings here with cerebrovascular adverse reactions in elderly patients with dementia-related psychosis, as I mentioned a second ago, and precipitation of opioid withdrawal in patients who are dependent on opioids because this combination medication does have an opioid antagonist. The dosing is stratified by indication, and the availability is in tablets. And again, being combination strength, we have a variable combo strength combo tablet available here. On the next slide, and the final slide for antipsychotics, we do have discontinuations, one being for Symbyax in July 2020. Eli Lilly announced discontinuing Symbyax 6 and 50 combo milligram medications and 12 and 50 milligram combo capsules. The distribution would continue until end of December 2020. And the other discontinuation was for Saffris in February 2021. Allergan had made a business decision to discontinue the 5 milligram sublingual tab presentation packaged in a box of 100. This was 10 blisters with 10 tabs, and the 10 milligram sublingual tablet packaged in a box of 100, again, 10 blisters with 10 tabs. All other packaging configurations continue to be available. I'll go ahead and pause right there for the committee, as that is the end of antipsychotics.
Thanks, Umang. Committee members, do you have any questions? Okay, I think we're ready then to go to our stakeholders. I have the following stakeholders listed, and I'll call you in the order that I list, starting with William O'Neill with Synovian, Ian D'Souza with Intracellular, Paul Thompson with Alkermes, Margaret Ullman with AbbVie, Carrie Carroll with Telecare, and Payal Tajani with Indivior. So I'll call each of you. You'll each have 3 minutes to speak. If you can please state your name and your affiliation, and if you're not clearly affiliated with a pharmaceutical company, can you please state if you have any financial ties to any pharmaceutical manufacturer? If you did not hear your name called, please raise your hand or sign in the chat to let us know that you're here and you want to be able to speak. All right, so we'll start with William O'Neill with Synovian.
Well, good morning. Thanks for the opportunity. I'm Bill O'Neill, Director of HEOR with Synovian Pharmaceuticals. And I'm here in support of retaining Latuda on the Washington State Preferred Drug List. Latuda is indicated for the treatment of adults and adolescents, that's ages 13 to 17 with schizophrenia, and in adults and pediatric patients ages 10 to 17 with major depressive episodes associated with bipolar 1 disorder. This is as monotherapy. Lurasidone is also approved as adjunctive therapy with lithium or valproate in adults with major depressive episodes associated with bipolar 1. The safety and efficacy of lurasidone in schizophrenia and bipolar depression has been established in multiple clinical trials. Now, in some short-term studies, treatment with lurasidone was associated with minimal changes in metabolic parameters, including weight, glucose, and lipid levels. And I'd refer you to the full prescribing information for a complete list of warnings, precautions, and adverse events. Now, the evidence-based guidelines from the 2018 CANMET and the International Society of Bipolar Disorders recommend lurasidone among first-line therapies as monotherapy or adjunctive therapy with lithium or divalproex for acute bipolar depression in adults. Now, lurasidone is also the only first-line agent recommended in children and adolescents with acute bipolar depression. In addition to the favorable clinical trial outcomes, lurasidone also consistently demonstrated favorable comparative health outcomes and cost effectiveness in adult patients with schizophrenia and bipolar disorder. In a Medicaid claims database analysis, adult patients with schizophrenia after switching to lurasidone monotherapy had numerically fewer all-cause and mental health-related hospitalizations and significantly shorter length of stay compared to those switched to quetiapine in a 6-month follow-up period. Also, an independent Humana claims database analysis found that patients with schizophrenia or lurasidone had substantially lower total medical costs, fewer hospitalizations and emergency room visits than aripiprazole, quetiapine, risperidone, olanzapine, and paliperidone. So just in conclusion, lurasidone addresses the need for a well-tolerated and cost-effective agent for patients with schizophrenia and bipolar depression. And I would like to respectfully request that lurasidone be retained on the PDL. And thanks for the opportunity this morning to speak to you, and I'd be happy to take any questions.
Thank you, Bill. Any questions from the committee for Bill? Okay, thanks. And just again, this is Virginia Bucola, Committee Chair. Just a word to Lita. Thank you for putting the timer up on the shared screen. I do note that it doesn't seem to be, on my view, doesn't seem to be updating. So I don't know if others are noticing that. So maybe to our presenters, we'll be using this, but I'm also I have a separate clock that hopefully will be more accurate. So I'm not sure.
Sorry.
Okay.
Can you just tell me what you mean by updating? Like you don't see it counting down?
It was freezing, so it sort of froze for me at 2:08. Yeah, it wasn't counting down.
Okay, thank you. Good
maybe
feedback.
we can keep trying it, but I don't know
Okay.
how accurate it will be right now for our presenters, depending on.
Okay, yeah, thank you.
Yeah,
Okay.
sure. Okay, next is Ian D'Souza with Intracellular.
Just a minute, I have to find him. Okay. Hey, Ian, can you unmute yourself?
Yeah, good morning. Can you hear me now?
Yes.
Yes, thank you.
Oh, thanks. So good morning. My name is Ian D'Souza. I'm an Executive Director with Medical Affairs representing Intracellular Therapies. And thank you for the opportunity to speak with you today about lumateperone, known by its brand name Caplyta, which is an atypical antipsychotic indicated for the treatment of schizophrenia in adults. As you know, and as among mentioned, schizophrenia remains a serious lifelong illness. There continues to be unmet needs among current treatments. In fact, the 2019 meta-analysis by Hune et al. In Lancet highlights that clinicians must balance the risk of various motor, metabolic, and prolactin side effects that contribute to distress, non-adherence, and ultimately relapse, which increase the overall social and economic burden of illness. So going to the clinical trials for Caplyta, Caplyta's approval for the treatment of schizophrenia in adults was based on 2 positive placebo-controlled randomized studies of similar design. In both studies, Caplyta 42 milligrams statistically significantly separated from placebo on the primary efficacy outcome, the PANSS total score. Efficacy was further corroborated by a clinician-rated CGI-S global severity scale, including clinical relevant improvements by PANSS responder analyses. Improvements were also observed across PANSS positive, negative, and general psychopathology subscales. In the short-term control trials, the most common adverse reactions with Caplyta 42 milligrams versus placebo was somnolence, sedation, and dry mouth. Mean metabolic changes from baseline and shifts to higher levels of fasting glucose, total cholesterol, and triglycerides was similar in patients on Caplyta or placebo. Changes in weight and prolactin level was similar to placebo, as were motor side effects. EPS rates were 6.7% for 3% using broad and narrow criteria and 2% for akathisia. Overall, 2% of patients, that's 2 patients or 0.5% on Caplyta and on placebo, discontinued due to adverse events. In an open label trial up to 1 year in patients with stable schizophrenia, the percentages of patients with shift from normal to high levels were 8% for total cholesterol, 5% for triglycerides, and 4% for LDL. Mean body weight decreased by approximately 4 pounds at 6 months and 7 pounds at 1 year, with 3 times as many patients experiencing a clinically significant weight decrease and an increase from baseline. Rates for EPS and akathisia were 5.3% and 0.5% respectively, and no new safety signals were observed. An additional 6-week open-label study also demonstrated low levels in body weight, BMI, cardiometabolic, and EPS-related effects associated with Caplyta. Efficacy was maintained in the longer open-label studies beyond 6 weeks and up to 1 year. Like other drugs in the antipsychotic class, Caplyta has a boxed warning that should not be used to treat dementia-related psychosis and other warnings and precautions associated with atypical antipsychotics, as described in the full prescribing information provided. Caplyta 42 milligrams is dosed once daily with food with a terminal half-life of 18 hours. It should be avoided with moderate and strong CYP3A4 inhibitors, inducers, UGT inhibitors, and persons with moderate to severe hepatic impairment. No difference was seen on the basis of patient's gender, age, or race. Thank you for your considering Caplyta without restriction on your formulary decision. I welcome any questions.
Thank you, Ian. Are there any questions from the committee? Okay, thank you. I'm also going to pause here just to be sure that the 2 stakeholders who've sent a message in the chat, Brandy Sig Martin and Hitlan Patadia, I've noted both of those names and added them to the list. Our next stakeholder is Paul Thompson with Alkermes. Paul, are you there?
Just give me a second to find. I think it might be helpful if everybody, all stakeholders who are signed up to speak can raise their hands, because then you go to the top of my list and I can find you really easy.
Oh, great. Can you hear me?
Yes, there you are. Thank you.
Yes, go ahead, Paul.
Okay, thank you. And thank you, Umang, for providing introduction to what I'm about to present today, and thanks for the opportunity to provide testimony on Lybalvi. I'm Paul Thompson. I'm the psychiatric pharmacist and medical science liaison at Alkermes. Lybalvi is a combination atypical antipsychotic olanzapine and opioid antagonist samidorphan, administered orally by tablet. I have the full prescribing information available and will be pleased to address any questions you have about the points I'm highlighting today. First off, there's a box warning for the increased mortality in elderly patients with dementia-related psychosis. Lybalvi is not approved for use in that population. Lybalvi is indicated for the treatment of schizophrenia or bipolar I disorder in adults. It is contraindicated in patients who are using opioids or who are undergoing acute opioid withdrawal. In patients who use opioids, delay initiating Lybalvi for a minimum of 7 days after last use of short-acting opioids and 14 days after last use of long-acting opioids. Administer Lybalvi once daily with or without food. Do not divide tablets or combine strengths. The efficacy of Lybalvi in the treatment of schizophrenia in adults is partly based on adequate and well-controlled studies of orally administered olanzapine. In study 1, adult patients who met DSM-5 criteria for schizophrenia were randomized in a 1:1:1 ratio daily to Lybalvi, olanzapine, or placebo for 4 weeks. The primary efficacy endpoint was the change in baseline positive negative symptoms scale, total score, week 4. Patients treated with Lybalvi showed a statistically significant improvement compared to placebo from baseline to week 4 in PANSS total score. In study 2, adult patients who met DSM-5 criteria for schizophrenia were randomized 1:1 to daily Lybalvi or olanzapine for 24 weeks. The co-primary endpoints were percent change in baseline body weight and the proportion of patients who gained greater than or equal to 10% body weight at week 24. The least squares mean change in body weight from baseline was plus 4.2% for Lybalvi and plus 6.6% for olanzapine. In the Lybalvi group, 17.8% of patients experienced weight gain greater than 10% of baseline body weight, compared to 29.8% in the olanzapine group. In both instances, the differences in co-primary endpoints were statistically significant. In adults with bipolar I disorder, the efficacy of Lybalvi was established based on adequate and well-controlled studies of orally administered olanzapine. The most common adverse reactions occurring greater than 5% or twice the rate of placebo for patients in schizophrenia were weight increase, somnolence, dry mouth, and headache. In bipolar I disorder, most common adverse events were dry mouth, constipation, increased appetite, dizziness across all groups. If Lybalvi is used as adjunct to lithium or valproate, additional adverse events included dyspepsia, weight gain, back pain, speech disorder, increased salivation, amnesia, or paresthesia. Now, samidorphan, which is a component of Lybalvi, is an opioid antagonist and can precipitate opioid withdrawal in patients who are dependent on opioids, which can lead to opioid withdrawal syndrome, sometimes requiring hospitalization. Attempting to overcome Lybalvi's opioid blockade by administering high repeated doses of exogenous opioids could lead to life-threatening or fatal opioid intoxication. Patients should be informed of the potential consequences of trying to overcome the opioid blockade and serious risks of taking opioids concurrently with Lybalvi while transitioning off Lybalvi. Thank you for the opportunity today to provide testimony on Lybalvi. I would like to see if the committee has any questions for me.
Thank you, Paul. This is Virginia. Anything, committee? Okay, thank you again.
And Virginia,
yes.
This is Paul. I did have a second testimony, not to take up the committee's time. Should I do that later?
The testimony, maybe Lita can guide us. I think it depends on what the testimony is in regards to.
Yeah, this is Lita. Is it also on an antipsychotic?
Yes, Aristata Initio would now be the appropriate time to provide testimony on that, or?
Yeah, I can give you another minute.
Okay, thank you. So it's still me, and I definitely want to thank the committee for letting me provide testimony on Aristata Initio. Aristata Initio is an atypical antipsychotic, and in combination with oral aripiprazole is indicated for the initiation of Aristata when used for the treatment of schizophrenia in adults. There's a boxed warning for increased mortality in elderly patients with dementia-related psychosis, and the only contraindication of those hypersensitive to aripiprazole. The main formulation difference between Aristata and Aristata Initio is the particle size of the aripiprazole Laroxyl crystals. Aristata Initio has much smaller size particles, and after injection releases aripiprazole faster than Aristata. Aristata Initio comes in one strength, 675 milligrams, and it should be given in conjunction with 30 milligram oral dose of oral aripiprazole to start the patient on Aristata therapy monthly, every 6 weeks, or every 2 months. Aristata Initio is only a single dose and not intended for repeated dosing. It needs to be injected intramuscularly by a healthcare professional and should be avoided to be injected in the same muscle as Aristata. Since there is a fixed dose for patients that have never taken aripiprazole before, oral tolerability should be established first. And since it's a fixed dose, it should be avoided in patients with 2D6 poor metabolism or patients on strong 2D6, 3A4 inhibitors or inducers.
Thank you, Paul.
All right, well, thank you.
I'm sorry to cut you off. Thank you very much. So next is Margaret Ullman with AbbVie.
This is Lita. Margaret, you should be able to unmute yourself now.
Thank you so much. Can you hear me?
Yes, Margaret, go ahead.
Good morning. My name is Dr. Margaret Ullman with Medical Affairs at AbbVie. I'm excited to be here today to talk with you about cariprazine, brand name Vraylar. Vraylar is a once daily oral medication for oral patients, adult patients, approved for the treatment of schizophrenia, the acute treatment of manic or mixed episodes of bipolar I disorder, and the treatment of depressive episodes associated with bipolar I disorder, also known as bipolar depression. I would like to highlight 3 important points about Vraylar for you. First, Vraylar has established safety and efficacy in 9 separate clinical trials, 3 trials for schizophrenia, 3 trials for manic or mixed episodes of bipolar I disorder, and 3 trials for bipolar depression. As such, and unlike most atypical antipsychotics, Vraylar treats the full spectrum of bipolar I disorder, manic, mixed, and depressive episodes. The most common adverse events of Vraylar include akathisia and extrapyramidal symptoms, although discontinuation due to these side effects was 2% or less in the pivotal studies. Vraylar has a neutral metabolic profile and minimal risk of weight gain, which is a common side effect with other antipsychotics. Vraylar does have most of the same warnings and precautions as other atypical antipsychotics, and I encourage you to review the full prescribing information at rxabv.com for complete safety and efficacy information. Second, I would like to bring to your attention Vraylar's unique pharmacologic profile. While the precise mechanism of action is not fully characterized, Vraylar is unique among the atypical antipsychotics for having the highest affinity for the D3 receptor. Vraylar is the only D3 preferring atypical antipsychotic available, which may have potential benefits on the difficult to treat symptoms of schizophrenia, such as predominant negative symptoms or cognitive defects. Lastly, Vraylar has an active metabolite, which contributes most of the antipsychotic activity with long half-life estimated to be between 1 and 3 weeks. This long half-life suggests that some continued effect may persist after the discontinuation of treatment. I believe this should be important to you as it may be beneficial in preventing rapid relapse in patients with intermittent adherence. In a 97-week schizophrenia relapse prevention trial where stable Vraylar patients were randomized to placebo or allowed to continue on Vraylar, the placebo group maintained prior treatment benefits over 6 weeks before increasing rates of relapse were seen. I'd like to close by respectfully asking that Vraylar be preferred for Washington Medicaid patients, and I'd be happy to answer any questions that you have today.
Thank you, Margaret. Committee, do you have any questions? Okay, thank you. Next is Carrie Carroll with Telecare.
Can you hear me?
Yes, I can hear you, Carrie. You'll have 3 minutes to speak. Go ahead.
Okay. Good morning. I'm Carrie Carroll, and I'm a psychiatric nurse practitioner, and I'm the psychiatric provider here at Telecare's Thurston Mason Crisis and Triage Facility in Tumwater. And I'm here to speak about issues to access for the clients I serve here with obtaining the therapy for the Aristada 2-month injectable. Most of the pushback I have experienced is with our contracted pharmacy has been with obtaining the Initio product. I have difficulties, either the pharmacy doesn't stock it or the prior authorization. But even after I've jumped through all those hoops, I get denials for the Medicaid and Medicare clients. And they give me the alternative of prescribing the 21-day PO Abilify instead of the Initio. And I have an issue with that because the population I serve here are come in crisis due mainly to poor medication adherence. These are homeless a lot of the time or have been incarcerated, and they have difficulty keeping their meds due to loss or difficulty with access. And some of our younger clients struggle with the stigma and difficulty of taking a pill daily. And as we know, poor medical compliance with these antipsychotics with this diagnosis of schizophrenia results in poor prognosis and quality of life over their lifespan. Also, this results in repeated hospitalizations, which is expensive and disrupts their lives and the lives of their caregivers and family. So lowering the risk of relapse with improved medication compliance is why this option of access to Aristada Initio is a medical need for these clients I serve. And I ask the committee with any help with the access for these patients, to improve access for these patients based on medical need. Thank you for your time.
Thank you, Carrie. Committee members, do you have any questions for Carrie? Okay. Next is Payal Tajani with Indivior.
Hi there, can you hear me?
Yes, I can hear you. When you're ready, you have 3 minutes.
Okay, perfect. Thank you, committee, for letting me speak today. My name is Payal Tajani, and I am a medical outcomes and value liaison with Indivior. Today, I'll be sharing information on Perseris, which is an extended release injectable risperidone product Perseris is indicated for the treatment of schizophrenia in adults. It does come with a boxed warning related to increased mortality in elderly patients with dementia-related psychosis. The most common adverse reactions for Perseris include increased weight, sedation, somnolence, and musculoskeletal pain. Perseris is administered once monthly via an abdominal subcutaneous injection, and it is available as a 90 milligram or 120 milligram dose. Those do correspond with a 3 milligram per day oral risperidone dose for the 90 milligrams and 4 milligrams of oral risperidone for the 120 milligrams. If patients haven't used risperidone in the past, they should be established on oral risperidone prior to treatment with Perseris to establish tolerability. Our pivotal phase 3 double-blind randomized placebo-controlled trial studied the change in positive and negative syndrome scale or PAN score from baseline to end of the study, which was day 57, and also at a secondary endpoint looking at the change in clinical global impression severity or CGIS score from baseline to end of study. We evaluated men and women aged 18 to 55 years that had who had schizophrenia per DSM-4 criteria. And we found that they did have a statistically significant improvement from baseline to day 57. In the PANSS total score, there was a reduction that was statistically significant, as well as a reduction in CGIS from baseline to end of study. The most common adverse reactions were headache, injection site pain, and weight gain. And we had 5 subjects that withdrew from the study because of adverse events. That was related to groin pain or paranoia. Some, important adverse warnings and precautions related to Perseris include cerebrovascular adverse reactions, including stroke in elderly patients with dementia-related psychosis, neuroleptic malignant syndrome, tardive dyskinesia, and metabolic changes. Thank you for your consideration of Perseris for your formulary, and if you have any questions, I'll open it up.
Thank you very much. Committee, do you have any questions for Piao? Okay, thank you. Then next on our list is Brandy Sieg Martin with Washington State Pharmaceutical Association.
Hello, thank you so much. My name is Brandy Sieg Martin. I'm a pharmacist and I represent pharmacists at the Washington State Pharmacy Association. The WSPA opposes requiring prior authorizations for antipsychotic agents. WSPA is comprised of pharmacists in many practice settings, including board-certified psychiatric pharmacists who provide care at in- and outpatient settings, including in the HCA program of Assertive Community Treatment Program. These care teams often need to make rapid dose or antipsychotic medication changes to manage acute symptoms and stabilize patients. Prior authorizations significantly limit their ability to rapidly address symptoms due to the delays that they pose. PAs may also cause delays in care when a patient has been released from an inpatient facility where they've trialed medications and stabilized the patient on an agent that is effective for them. But then on discharge, the patient and their family show up at the community pharmacy only to find that the medication they need requires a PA. This delays care and puts the patient at risk. Additionally, PAs need to be reauthorized every year. This also puts a patient at risk of destabilization. When perhaps all has been going well, but 1 month they go to refill their prescription and it requires a PA. Now the patient may have to go without medication for a period of time. This can be a critical time when patients may decide they don't need their medications at all. They're feeling stable and the cycle starts again. To address issues of misprescribing with respect to antipsychotics, WSPA supports annual medication reviews and quality metrics that assess appropriate prescribing and care. Prior authorizations for antipsychotic medications hurt patients, families, and our communities. We already have a major shortage of mental health care facilities and providers. Requiring PAs bogs down an already stressed system and poses undue barriers and risks for patients to get the treatment they need. Thank you so much for your consideration.
Thank you very much. Any questions from the committee for Brandy? Okay, And our last stakeholder is Hitin Patadia with Otsuka.
Hi, can you hear me?
Yes, I can hear you. Go ahead, you have 3 minutes.
Great. My name is Hitin Patadia. I'm a pharmacist by training. I'm a managed market liaison with Otsuka Pharmaceutical Development and Commercialization. Thank you for the opportunity for me to provide testimony on Abilify Maintena to the Washington Medicaid. I believe you've all received or have reviewed the full prescribing information, so I would just like to highlight a few clinical points. Schizophrenia is a heterogeneous disorder with a wide range of potential genetic, environmental, and psychosocial factors that may impact its clinical course. Results from several studies suggest that there's substantial interpatient variability in responses to different antipsychotic medications. Mental health professionals agree that it is very important to match antipsychotic agents to the individual patient needs. Drug utilization management policies that hinder access to medications and continuity in care may interfere with treatment. One study by West et al. Examined medications among psychiatric patients in 10 state Medicaid plans to evaluate adverse events associated with medication access issues. Results showed that patients with access issues had 3.6 times greater likelihood of adverse events, including ER visits, hospitalization, homelessness, suicidality, or incarceration. Based on these findings, it was concluded that the access to full range of medication facilities facilitates optimal disease management for psychiatric patients. Bipolar disorder is also a serious, lifelong episodic illness characterized by the occurrence of one or more manic episodes. Episodes of mania are recurrent and commonly associated with negative outcomes, including decline in cognitive function and increase in hospitalizations. Bipolar I disorder is associated with significant medical and psychiatric comorbidity, premature death, functional disability, and reduced quality of life. Long-term pharmacological treatment is necessary to prevent recurrence of symptoms and relapse. The chronic nature of bipolar I disorder and the negative consequences of unremitted or recurrent symptoms emphasize the need for effective long-term treatment. Otsuka Pharmaceutical Development and Commercialization supports an open access policy to allow for individualized and appropriate treatment of patients with serious mental illness. Abilify Maintena is approved for an extended release injectable suspension. It's an atypical antipsychotic, and it's indicated for the treatment of schizophrenia and for the maintenance monotherapy of bipolar treatment and for bipolar I. On July 29, 2017, Abilify Maintena was approved by the FDA as a first monthly long-acting injectable for maintenance monotherapy of treatments of bipolar I disorder in adults. In fair balance, I'd like to call your attention to the box warning for Abilify Maintena, increased mortality in elderly patients with dementia-related psychosis. For the complete box warning and additional information, please refer to the PI for Abilify Maintena. Abilify Maintena activity is presumably due to the parent drug aripiprazole, to a lesser extent its major metabolite dihydroaripiprazole.
Titan, I'm sorry to interrupt. Your 3 minutes are up.
Okay, thank you so much.
Thank you very much. Are there any questions from the committee? Okay, thank you. Are there any stakeholders that were missed?
This is Lita. I do not see any other hands raised.
Okay, I see actually Kavita has a question.
Hi there, Kavita Chavla. May I ask a question to, was it Brandy who was representing WSPA?
Yeah, I go ahead and I can unmute her again.
Okay. My question is, does WSPA have any metrics to share about what percentage of antipsychotic prescriptions are rejected up front and require a prior auth? Are there any metrics that track this?
I don't have that information at this time, but I can definitely do some research and get back to you with that.
Thank you.
Thanks, Kavita. Okay, so I think we're ready to move to our motion. We have two motions. The first is on second generation antipsychotics and combination products. And then we'll do a separate motion for Parkinson's. At least how we have it written on our agenda is Parkinson's psychotic disorder, but I don't know if there's meant to be a slash there. All right, so team, if you want to bring your cameras up so we can see each other.
This is Leah Marcotte. I move that all products in the drug classes listed on slide 2 are considered safe and efficacious for their medically acceptable indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Virginia Bucola, and I second that motion. And again, this is Virginia Bucola, committee chair. All those in favor, please say aye.
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 Are there any opposed? Okay, the motion carries.
This is Lita. Marissa, I do not see a second motion for Parkinson's. Can you address that? Do you want me to?
Yeah, I'm seeing that there's not one either. So I think we'll probably just need to create it. I apologize. I thought that there was one.
Okay.
Should we, this is Virginia, can we return to that after the break?
That would be helpful.
Give you enough time to create that? Okay.
Thank you.
Okay, yeah, thanks everybody. Okay, so then we'll go back to Umang to review cytokine and CAM agents.
Alrighty, this is Umang. All right, we'll pivot over to cytokine and CAM antagonists. Before we dive right into it, just to inform the committee, as you can imagine, there are a lot of different disease states and medications that fall under here that can have dual, triple indications for various disease states. I've done my best to give background on all the disease states in which there are significant clinical updates for medications in the last year. And so we'll be going through the umbrella disease states, and then we'll pivot over to new clinical information. On the next slide, just a little bit of background. Cytokine and cell adhesion molecules, or CAMs, are chemical mediators involved in the inflammatory process throughout the body. Cytokines are small proteins secreted in response to an immune stimulus for the purpose of mediating and regulating immunity, inflammation, and hematopoiesis. The actions of the individual cytokines are widely varied, and they contribute to fibrosis and tissue degeneration associated with chronic inflammation, primarily by inducing the proliferation of fibroblasts and collagenase. The pro-inflammatory cytokines, TNF and IL-1, are involved in tissue destruction in many chronic inflammatory diseases affecting various organs. On the next slide, the cell adhesion molecules are cell surface proteins involved in binding of cells, usually leukocytes, to each other, endothelial cells, or the extracellular matrix. Specific signals produced in response to wounds and infections control the expression and activation of these molecules. Most of the CAMs categorized fall into 3 general families of protein. There's the Ig superfamily, the integrin family, and the selectin family. Other proteins that are functionally classified as CAMs are involved in strengthening the association of T cells with antigen-presenting cells or target cells and T cell activation, and recirculating lymphocytes back to the circulation via the lymphatic system. And different CAMs have been implicated in inflammatory, fibrotic, and autoimmune diseases. On the next slide here, we'll pivot over to juvenile idiopathic arthritis. There are guidelines from 2019. Again, it is over a year old. I've kind of bolded the relevant updated information regarding DMARDs for polyarthritis. Methotrexate is usually recommended over leflunomide or sulfasalazine, and sub-Q methotrexate is conditionally recommended over oral methotrexate. For biologic DMARDs in patients with polyarthritis, Combination therapy with a DMARD is conditionally recommended over biological monotherapy when initiating treatment with a biologic. I know there's a lot of information here. Because it being over 1 year old, I just wanted to highlight some of the significant points here. Continuing on to the next slide, in terms of the ACR Arthritis Foundation, for initial therapy in polyarthritis patients, they recommend all patients have initial therapy with the DMARD over NSAID monotherapy. And in patients without risk factors, which are things such as positive anticyclic, citrulline peptide antibodies, positive rheumatoid factor, or presence of joint damage, they recommend initial therapy with the DMARD conditionally over a biologic. For subsequent therapy in low disease activity patients, defined as clinical juvenile disease activity score, they recommend escalation of therapy. And this is, for example, intra-articular glucocorticoid injection, DMARD dose optimization, methotrexate trial, and adding a changing biologic, and that is recommended over no escalation. For subsequent therapy in moderate or high disease activity, patients receiving DMARD monotherapy, the group conditionally recommends adding a biologic to the original DMARD over changing to a second DMARD or a triple. For subsequent therapy in moderate or high disease activity in polyarthritis, patients receiving a TNF antagonist with or without a DMARD, they recommend switching to a non-TNF antagonist over switching to a second TNF antagonist. However, a second TNF antagonist may be appropriate in patients with good initial response to a TNF antagonist who have experienced secondary failure. And if the patient is receiving their second biologic, use of a TNF antagonist, abatacept, or Tosilizumab is conditionally recommended over rituximab. Continuing onward, for patients with juvenile idiopathic arthritis and sacroiliitis, guidelines strongly recommend treatment with an NSAID over no NSAID therapy. In those who already are on NSAIDs with continued active disease, they recommend a TNF antagonist over NSAID monotherapy. The group strongly recommends against the use of methotrexate monotherapy. Bridging therapy with a limited duration of oral corticosteroid in select conditions and adjunct to use of intra-articular glucocorticoid are conditionally recommended. For those with juvenile idiopathic arthritis and enthesitis, the group strongly recommends NSAID treatment over no NSAID treatment. With a TNF antagonist conditionally recommended over methotrexate or sulfasalazine. And bridging therapy with a limited duration oral corticosteroid in select conditions also is conditionally recommended. And there are additional recommendations on specific glucocorticoids. Moving over to pediatric psoriasis, the American Academy of Dermatology and National Psoriasis Foundation published guidelines for this, and they recommend ongoing assessment of psoriatic arthritis, uveitis, obesity, CV risk factors, dyslipidemia, insulin resistance, and mental health conditions, and the body surface area plus children's dermatology life quality index should be used to assess severity. In terms of treatment, they recommend topical treatments, and there's a litany of medications here. For systemic treatments, they include medications such as methotrexate, cyclosporin, systemic retinoids, biologics, etanercept, infliximab, adalimumab, and ustekinumab. And lastly, guidelines recommend treatment of physical and psychosocial wellness, quality of life in pediatric patients with pediatric psoriasis as well. Pivoting over to ankylosing spondylitis. So axial spondyloarthritis is an inflammatory condition generally affecting the spine and can be further subdivided into ankylosing spondylitis and non-radiographic ankylosing spondylitis. The American College of Rheumatology, the Spondylitis Association of America, and the Spondyloarthritis Research and Treatment Network published 2019 updates on the treatment of ankylosing spondylitis and the non-radiographic axial spondyloarthritis. They generally recommend, in general, the recommendations for ankylosing spondylitis and non-radiographic ankylosing spondylitis are similar. TNF antagonists, not a specific agent, are recommended as first biologics over a second TNF. TNF antagonists are recommended as first biologics over Cosentyx or Tremphio, which are then recommended over a second TNF antagonist if first dose does not produce a response. All prior mentioned agents are recommended over Xeljanz. Concurrent low-dose methotrexate with TNF antagonist is not recommended. They recommend against a strict treat-to-target strategy. If a patient's disease is stable, guidelines recommend against discontinuing or tapering of biologics. And sulfasalazine provides a viable option for select patients who cannot take a TNF antagonist.
Sorry about that.
No problem. No worries. I think we're probably around slide like 20 or so, Lita.
Thank you. Sorry, I had to open the motions back up.
No, you're okay.
Okay. So next one.
Next slide, I believe. Yep, perfect.
Thank you.
Next, anytime. This is Umang again. Next, we have periodic fever syndrome. Now, these are rare hereditary syndromes that are characterized by short, recurrent, severe localized inflammation and fever attacks that are not otherwise explained by routine childhood or adult infections. It is defined as 3 or more episodes of unexplained fever in a 6-month period occurring at least 7 days apart. These can occur periodically or irregularly and undergo spontaneous remission. CAPS is a family of syndromes associated with mutation in cryopyrin, now known as nucleotide binding domain and leucine-rich repeat-containing family. CAPS include Muckle-Wells syndrome, familial cold autoinflammatory syndrome, chronic infantile neurologic cutaneous articular syndrome, which is also known as neonatal onset multi-system inflammatory disease. Now, in terms of treatment, Kineret, Ilaris, and Arcalyst are approved for the treatment of CAPS in select ages. Kineret is only approved for patients with CAPS associated with NOMID, and Arcalyst and Ilaris are approved for more generally for patients with CAPS, including FCAS and MWS. Ilaris is also approved for the following other periodic fever syndromes, such as tumor necrosis factor receptor associated periodic syndrome, hyperimmunoglobulin D syndrome, and familial Mediterranean fever. On the next slide, we have giant cell arteritis, and this is, or temporal arteritis, is a systemic inflammatory vasculitis of unknown etiology that is classified as a large vessel vasculitis, but typically also involves small and medium arteries. Most commonly, it affects the occipital, ophthalmic, posterior ciliary, proximal vertebral, and vertebral arteries. While the incidence ranges from 0.5 to 27 cases per 100,000 people in those 50 years of age or older, the incidence is higher in the northern areas of the US, and it occurs in older people and can result in a wide variety of neurologic, ophthalmologic, and systemic complications. In terms of treatment, high-dose corticosteroids, although clinical studies on various dosing protocols are limited. Steroids are generally continued until resolution of symptoms and then may be tapered slowly to the lowest dose that adequately suppress symptoms. And Actemra is the only non-corticosteroid drug FDA approved for the treatment of giant cell arteritis. Next, we have Hirsutensis suppurativa. This is a chronic condition that affects the terminal follicular epithelium in the apocrine gland-bearing skin, such as the armpits or the perianal area. It typically occurs in adolescents, generally after puberty, and adults, is generally diagnosed clinically, and affects approximately 1 to 2% of the US population. Select signs and symptoms include erythema, raised bumps or lesions, painful lesions, local arthritis, or arthralgia. In addition to non-pharm treatments, pharmacological treatments include anti-inflammatories, antibiotics, anti-androgens, biologics such as Remicade, and surgery may also be considered in some patients. In terms of guidelines, they are somewhat outdated. The European Dermatology Forum from 6 years ago released guidelines for the treatment and are limited, but guidelines from the European Dermatology Forum recommended either adalimumab or infliximab in severe or refractory disease, stating adalimumab appears, I apologize, this pop-up, there we go, stating adalimumab appears to be better tolerated. However, only adalimumab is approved by the FDA for this use. And in terms of uveitis, it is a non-infectious intermediate and posterior uveitis, inflammation of the immediate and posterior uvea, while panuveitis is inflammation of the anterior chamber, the vitreous humor, the choroid, and the retina simultaneously. Together, these represent the most severe and highly recurrent form of uveitis, and the incidence of all cases of uveitis is approximately 15 per 100,000 patients per year, and the anterior uveitis is the most common form. On the next slide here, in terms of treatment, the ACR and Arthritis Foundation in 2019 published guidelines. I'll do my best to kind of summarize with the underlined information. But they published guidelines on the recommendation of uveitis associated with juvenile idiopathic arthritis, one of the most common extra-articular manifestations of JIA. And the group recommends select topical glucocorticoids in patients with JIA and active chronic anterior uveitis for short-term control. But for those who are unable to control symptoms with short-term therapy, they recommend adding systemic therapy in order to taper topical glucocorticoids. For juvenile idiopathic arthritis patients who develop new chronic anterior uveitis despite stable systemic therapy, they recommend topical glucocorticoids prior to changing or escalating systemic therapy. Regarding specific agents, they recommend subcutaneous methotrexate conditionally over oral methotrexate. However, use of a TNF antagonist with methotrexate in severe active disease and sight-threatening complications is conditionally recommended over methotrexate monotherapy. If starting a TNF antagonist, they conditionally recommend a monoclonal antibody over etanercept. Abatacept and Tosilizumab as biologics and mycophenolate leflunomide or cyclosporin as non-biologic options are conditionally recommended in patients who have failed methotrexate and 2 monoclonal antibody TNF antagonists. For pediatric patients with spondyloarthritis who develop acute anterior uveitis, the group conditionally recommends topical glucocorticoids prior to a change in the systemic therapy. And notably, the only agent approved for uveitis in this class is adalimumab. On the next slide, we have cytokine release syndrome, and that can occur following select immunotherapies and result in a large rapid release of cytokines in the blood. This manifests as fever, nausea, headache, rash, tachycardia, hypotension, dyspnea, and can be life-threatening. Actemra is approved for the treatment of CAR T-cell induced severe or life-threatening cytokine release syndrome in adults and pediatric patients 2 years of age or older. Now, to pivot over to the role of biosimilars. In 2017, the ACR published a white paper regarding the use of biosimilars in treatment of rheumatic diseases and provides a comprehensive overview of the scientific, clinical, economic, and prescribing issues pertaining to biosimilar use, including efficacy and competition. They note that available real-world studies have demonstrated efficacy for extrapolated indications and state that healthcare providers should incorporate biosimilars where appropriate into treatment for patients with rheumatologic diseases. As an internal multidisciplinary task force issued a consensus-based recommendation on the use of biosimilars for rheumatologic diseases, focusing on multiple factors, including extrapolation of indication and switching between originator and biosimilar. They state treatment is a shared decision between patient and clinician, and patients and providers must be educated on biosimilars. In addition, they are not considered superior or inferior to the originator product, and biosimilars should be considered safe and effective for all the originator's products' approved indications. Notably, the guidelines recommend against interchangeability without consultation with a prescriber. Next slide here, we have ulcerative colitis. And so this is a chronic inflammatory disease primarily affecting the colon and rectum. It affects approximately 1 million people in the US, and the incidence continues to increase worldwide. The CDC estimates the current prevalence of ulcerative colitis is 238 per 100,000 adults. And it may present at any age, but onset typically peaks between 15 and 30 years of age. The disease is characterized by superficial infiltration of the bowel wall by inflammatory white cells, resulting in multiple mucosal ulcerations and crypt abscesses. The predominant symptom is diarrhea, which is usually associated with blood in the stool. Additional symptoms may include pain in the lower quadrant or rectum, along with systemic features, including fever, malaise, weight loss, which is more common if a greater portion of the colon is affected. The initial attack may be fulminant with bloody diarrhea, but the disease more commonly begins indolently, with non-bloody diarrhea progressing to bloody diarrhea. It can present initially with any extent of anatomic involvement, ranging from disease confined to the rectum to the whole large intestines, and that is defined as pancolitis. And most commonly, this follows a chronic intermittent course with long periods of quiescence interspersed with acute attacks lasting weeks to months. However, a significant percentage of patients suffer a chronic continuous course. On the next slide, the American Gastroenterology Association last year released guidelines. For moderate to severe ulcerative colitis, they recommend considering patients with moderate to severe disease to be those who are dependent on or refractory to corticosteroids, exhibit ulcers upon endoscopic assessments, or at high risk of colectomy. Long-term management can include medications from the following classes: TNF alpha antagonists and immunomodulators, the anti-integrin agent Vedolizumab and JAK inhibitors. If the agent selected for inducing remission is effective, it is usually continued as maintenance therapy. The exception to this would be when corticosteroids or cyclosporin are used for indication of remission. The following agents are recommended over no treatment for adults outpatient with moderate to severe ulcerative colitis, listed in order of a FDA approval: infliximab, adalimumab, golimumab, vedolizumab, tofacitinib, and ustekinumab. In patients who are biologic naive, infliximab or vedolizumab are suggested rather than adalimumab for induction or remission. However, patients with less severe disease who value the convenience of self-administration over the relative efficacy of therapy may select adalimumab instead. For induction of remission, thiopurine monotherapy is suggested against use. However, it is suggested over no treatment for maintaining remission. Methotrexate monotherapy is suggested against use for induction as well as maintenance of remission. The combination of TNF alpha antagonists such as vedolizumab or ustekinumab is suggested with thiopurines or methotrexate over biologic monotherapy or thiopurine monotherapy. Early use of biologics with or without use immunomodulator therapy is suggested rather than gradual step up to these agents following the failure of 5-ASA. And additional recommendations for adult outpatients with moderate to severe ulcerative colitis are provided regarding the use of tofacitinib and management of non-responders to infliximab. And for those who achieve remission with biologic agents and or immunomodulators or tofacitinib, it is suggested against using 5-ASA for induction and maintenance of remission. On the next slide, the AGA published guidelines this year for the management of moderate to severe luminal and fistulizing Crohn's disease in adult outpatients as well. And they recommend anti-TNF alpha therapy over no treatment for induction and maintenance of remission. Ustekinumab is recommended and vedolizumab is suggested over no treatment. They recommend against natalizumab over no treatment for induction and maintenance. And infliximab, adalimumab, or ustekinumab are recommended over certolizumab pegol, and vedolizumab is suggested over certolizumab pegol for induction in patients naive to biologics for Crohn's disease. Okay, now we will pivot from background and guidelines over to new clinical updates and medications. First, we have Stelara. In July 2020, FDA approved expanded indication for patients with moderate to severe plaque psoriasis who are 6 years of age or older. Previously, it was indicated only in patients 12 years of age or older. Just to remind the committee, when there are expanded indications, new formulations, things such as that, I try to bold the relevant data on or information on the slide so you can kind of go immediately to what is new. So as I mentioned, Stelara's indication for pediatric patients increased from 12 years of age down to 6 years of age. All other information remains the same. Limitations, dosing is stratified by indication, and that can be found in the TCRs or the package insert, and availability. In terms of pregnancy, patients who are pregnant with this medication, there's limited available human data for use in pregnant women, and there's insufficient data to form a drug-associated risk, and there are no formal trials of this medication on patients with hepatic or renal impairment. On the next slide here, we have the medication Julio. In July 2020, FDA approved this medication, which is a biosimilar to Humira. It is a TNF antagonist approved for the treatment of adults with moderate to severe active rheumatoid arthritis, juvenile idiopathic arthritis in patients 4 years of age or older, psoriatic arthritis in adults, active ankylosing spondylitis in adults, moderate to severe active ulcerative colitis, moderate to severe active Crohn's disease, and moderate to severe plaque psoriasis. In terms of limitations, there are black box warnings. Again, it is a biosimilar to Humira. There's an increased risk of severe infections leading to hospitalizations or death, including TB, bacterial sepsis, invasive fungal infections, and infections due to other opportunistic pathogens. A second black box warning for lymphoma and other malignancies, some fatal, have been reported in children and adolescent patients treated with DNF blockers, including adalimumab products. Serious infections, there's a warning for serious infections, so do not start this medication during an active infection. If an infection develops, monitor carefully and stop if the infection becomes serious. The dosing is stratified by its various indications, and that can be, again, be found in the TCR and PI. And the availability are injection, there are pre-filled pens, pre-filled plastic syringes in 40 milligrams and 20 milligrams as well. In terms of special population, for patients who are pregnant, there are limited available human data with Julio for use in pregnant women. So there's insufficient data to inform a drug-associated risk. And again, no formal trials for the of this medication on patients who are hepatic and renally impaired. Next, we have Tremphio. This medication in July 2020, FDA approved a new indication for psoriatic arthritis. As you can see, it already had an indication for the treatment of adult patients with moderate to severe plaque psoriasis who are candidates for systemic therapy or phototherapy. All other information remains the same, no changes in limitations or availability. And as you can see, the dosing for active psoriatic arthritis is the same as for plaque psoriasis here. Similar to some of the other biologics, no available data in pregnant women to inform a drug-associated risk. There has been no safety and efficacy in pediatric patients 18 years of age or younger. Younger than 18 years of age. And again, no specific studies in patients who are renally or hepatically impaired. Next, we have Ilaris. In September 2020, FDA approved Ilaris for active Still's disease, including adult onset Still's and systemic juvenile idiopathic arthritis in patients 2 years of age or older. As you can see, it does have a list of other indications as well. No changes in limitations. The dosing, again, is stratified by indication, and the availability are injections in single-dose vials. Identical to the previous medications listed, insufficient information to inform a drug-associated risk in pregnant women, and no formal trials for hepatically or renally impaired patients. All right, next we'll go on to Enspryng. In August 2020, the FDA approved Enspryng, which is an IL-6 receptor antagonist for the treatment of neuromyelitis optica spectrum disorder in adult patients who are anti-aquaporin 4 antibody positive. In terms of limitations, there can be infections. Delay administration in patients with active infections until the infection is resolved. Vaccination with live or live attenuated vaccines is not recommended. It is recommended to monitor ALT and AST during treatment, as it can elevate liver enzymes, and to monitor neutrophil count during treatment, as it can decrease the patient's neutrophils. In terms of dosing, there are, as I mentioned prior to the infections, Hep B, tuberculosis, and LFT screenings need to be done before the first dose. Prior to every use, determine if there's an active infection, and the recommended loading dose for the first 3 administrations is 120 milligrams by sub-Q injections at week 0, 2, and 4, followed by a maintenance dose of 120 every month. The availability comes in 120 milligram per mil single dose pre-filled syringe. And similar, again, to the previous medications, there is insufficient data to develop a risk in pregnant women and no formal trials for hepatic and renal impairment. and it has not been studied in pediatric patients yet. Excuse me, safety and efficacy has not been established in pediatric patients yet. On the next slide here, we have Xeljanz and Xeljanz XR. Now, in September 2020, FDA approved Xeljanz 1 milligram per ml oral solution and Xeljanz tablets for the treatment of polyarticular coarse juvenile idiopathic arthritis in patients 2 years of age or older. As you can see, Xeljanz and Xeljanz XR already have a number of other indications. No changes to any of the warnings, including the boxed warnings of infection, thrombosis, or lymphoma. The dosing here is stratified by indication, and again, there was a new oral solution of being 1 milligram per ml. The XR tablets and tablets already exist. Okay, next we have Simponi Aria. Now, in October 2020, there were two different changes. First being the FDA-approved Simponi Aria for the treatment of active polyarticular juvenile idiopathic arthritis in patients 2 years of age or older. Additionally, they also expanded indication for the use in psoriatic arthritis to include children as young as 2 years of age or older. Previously, it was only adults. So as you can see, it also has other indications such as rheumatoid arthritis and ankylosing spondylitis. No changes in limitations whatsoever or availability, just the two new indications were added in. And again, no adequate studies in pregnant women to assess a drug interaction, and no formal studies for hepatically or renally impaired patients. Next, we have Kineret, where in December 2020, FDA also expanded the indication for use in treatment of deficiency of interleukin receptor antagonist. It already has other indications for rheumatoid arthritis and cryopyrin-associated periodic syndrome, CAPS. No changes in warnings or availability whatsoever, and the dosing is stratified by indication. Now, in terms of pediatric use, this medication does have pediatric indications for NOMID and DIRA. In terms of geriatric population, because there's a higher incidence of infection in elderly population in general, caution should be used in treating the elderly. This drug is known to be substantially excreted by the kidney, and the risk of toxic reaction to this drug may be greater in patients with impaired renal function, so clinicians should monitor renal function as well. And patients with hepatic impairment, there were no formal studies to show hepatically impaired patients on Kineret. Moving onward to Arcalyst. Arcalyst received two new updates. The first being in December 2020, the FDA expanded indication for the use and treatment of deficiency of interleukin-1 receptor antagonist. And then in March of 2021, FDA expanded indication for the use and treatment of recurrent pericarditis and reduction in risk of recurrence in adults and children 12 years of age or older. As you can see, there were already a list of other indications, primarily surrounding CAPS and the subgroups that fall under CAPS. No changes in the warnings of serious infections, hypersensitivity reaction, or immunizations. Again, dosing is stratified by indication here, and the availability, no changes in availability for Arcalyst. For Arcalyst, oh, sorry, Lita, if you could go back really quickly. For Arcalyst, no studies have been conducted to evaluate PK differences in hepatically or renally impaired patients. However, based on animal data, this medication could cause fetal harm in patients who are pregnant. Okay. Moving onward to Humira. So in February 2021, FDA expanded the indication for treatment of moderate to severely active ulcerative colitis to include patients as young as 5 years old. It already has a lot of other indications, as you can see here. And similar to all the other medications with expanded indications, no changes to their warnings or their availability here, just the expanded indication, and the dosing is stratified by indication, age, and weight. Which can be found in the TCR or the package insert. Okay. Moving onward, we have Actemra. And so in March 2021, FDA issued the emergency use authorization for Tosilizumab, an IL-6 blocking monoclonal antibody for the treatment of hospitalized adults and pediatric patients 2 years of age or older for COVID-19 who are receiving systemic corticosteroids and require supplemental oxygen, non-invasive or invasive mechanical ventilation, or extracorporeal membrane oxygenation, ECMO. Actemra is already approved for the treatment of select patients with rheumatoid arthritis and interstitial lung disease, giant cell arteritis, and juvenile idiopathic arthritis. No other changes in warnings or availability, and dosing is stratified again by indication, age, and weight. All right, on the next slide, we have our last medication update. And so in June 2021, FDA expanded the use for Cosentyx for moderate to severe plaque psoriasis in patients who are candidates for systemic therapy or phototherapy to include patients 6 years of age or older. Previously, this was only in adults. No other changes to warnings, which include infections, TB, which stems off of infections, inflammatory bowel disease, and immunizations. No changes to availabilities, which can be found in injection form. And the dosing, again, similar to its three predecessors on this slide deck, are stratified by indication, age, and weight. On the next and last slide for cytokine and CAM antagonists, we have just some updates in terms of discontinuations, FDA communication, and REMS updates. So in terms of discontinuation, in July 2020, AbbVie reported to the FDA plans to discontinue the 10 milligram per 0.2 milliliter and 20 milligram per 0.4 milliliter pre-filled syringe presentations of Humira based on market assessment and product demand. For FDA communication, in February 2021, Xeljanz and Xeljanz XR, FDA alerted the public that preliminary results from a safety clinical trial show an increased risk of serious heart-related problems and cancer compared to TNF inhibitors. FDA advises patients should not stop taking prescribed medication without consulting their physician, and FDA will communicate final conclusions and recommendations once the review is complete. And in February 2021 for Saliq, there was a REMS update. Various updates to the REMS material, including conversion of the REMS document to a new format and removal of the program from titles of the REMS material. Additionally, changes were made to the stakeholder enrollment form and patient enrollment form, as well as to the REMS material to align with changes to the new REMS document. I'll go ahead and pause there for the committee.
Thanks, Umang. Thanks very much. That was really thorough.
Thank you.
Yeah. Did I give enough time for the committee to formulate any questions or turn their cameras on? Okay. If there aren't any questions, then we have two stakeholders, Margaret Ullman with AbbVie and Carrie Johnson with Amgen. If you did not hear me call your name, please go ahead and raise your hand, or in the chat, let us know that you're here and you are requesting stakeholder time. All right, so Lita, when you're ready, let's go ahead and start with Margaret Ullman with AbbVie.
Hi, can you hear me?
Yes, I can. Thanks, Margaret. You'll have 3 minutes to present. Thanks.
Hello, my name is Dr. Margaret Ullman from Medical Affairs at AbbVie. Thank you for the opportunity to speak with you today. AbbVie now has 3 targeted immunomodulating medications available. I'd like to briefly review Skyrizi, Rinvoq, and Humira and answer any questions you might have. Please see the full prescribing information for all 3 products at rxabbvie.com for comprehensive safety and efficacy data. Skyrizi is an IL-23 inhibitor indicated for the treatment of moderate to severe plaque psoriasis in adults and is given as a subcutaneous injection at week 0, 4, and every 12 weeks, which means 4 doses per year for maintenance treatment. In the 4 phase 3 clinical trials, it met all primary and ranked secondary endpoints. Skyrizi showed superior efficacy to Stelara in both PASI 90 and PASI 100 responses at 16 and 52 weeks. After 2 doses, 75% of patients had at least a 90% improvement in their PASI score, increasing to 83% of patients after 1 year of treatment. Skyrizi also showed a statistically significant difference versus Humira in PASI 90 at week 16 and after a switch from Humira in intermediate responders. The incidence of adverse reactions in the integrated analysis were similar for Skyrizi, Humira, and Stelara in both the long and short term. There were no unexpected safety findings, and there are no contraindications for treatment. Rinvoq is an oral JAK inhibitor indicated for the treatment of adults with moderately to severely active rheumatoid arthritis, given as a 15 milligram oral tablet once daily. In the phase 3 clinical program, Rinvoq met all primary and ranked secondary endpoints in all 5 clinical trials, and significantly more patients achieved DAS28 remission and low disease activity versus controls in each trial. Rinvoq is the only approved JAK inhibitor to demonstrate inhibition of joint damage in its approved patient population of methotrexate IR patients. It is also the only targeted immunomodulator to show clinical superiority to Humira plus methotrexate. The most common adverse reactions in the upadacitinib trials were upper respiratory tract infections, nausea, cough, and fever. As you recall, Humira has 10 currently approved indications. With long-standing safety data, 71 clinical trials, 18 years of marketed experience, and over 1 million patients exposed, Humira has a well-defined published benefit to risk database. In summary, I respectfully urge the committee to maintain preferred status of Humira on the PDL and to add Skyrizi and Rinvoq as available treatments for your state Medicaid patients. Thank you, and I'd be happy to answer any questions you might have.
Thank you, Margaret. Committee members, do you have any questions for Margaret? Okay. Next is Carrie Johnson with Amgen.
This is Lita. Carrie, you can unmute yourself. Okay, she may have stepped away. I see that Shirley Koch. Could you please raise your hand, Shirley? Thank you. All right, go ahead, Shirley.
Great. Can you hear me?
Yes, you go ahead, Shirley. Your 3 minutes will start now.
Okay. Good morning, Washington PNT committee members. My name is Shirley Quach, and I am a population health MSL with Novartis Pharma. I just want to first thank you for the thorough and thoughtful review of the targeted immune modulators class, and just for this opportunity to provide some updates regarding Cosentyx, secukinumab, the first and only fully human interleukin inhibitor that's indicated for plaque psoriasis, psoriatic arthritis, ankylosing spondylitis, and non-radiographic axial spondyloarthritis. And these are a group of related diseases driven by interleukin 17A. So on May 28th of this year, the FDA approved Cosentyx for the treatment of moderate to severe plaque psoriasis in patients 6 years and older who are candidates for systemic therapy or phototherapy. Cosentyx was evaluated in a 52-week randomized, double-blind, placebo and active controlled trial in 162 pediatric patients that were 6 years of age or older with severe plaque psoriasis. And these patients were candidates for systemic therapy. The study met the co-primary endpoints. Both Cosentyx doses were superior to placebo with respect to the PASI 75 response and IGA 0/1 response at week 12. The study also met the key secondary endpoints. Both Cosentyx doses were superior to placebo with respect to PASI 90 response at week 12. And the safety profile for Cosentyx was consistent with the adult phase 3 studies, with no new safety signals that were identified. To date, Cosentyx has been prescribed to over 500,000 patients worldwide since launch, with over 5 years of consistent long-term efficacy and safety data, and over 100 clinical studies and a comprehensive head-to-head clinical trial program. Thank you for your time and consideration, and I'd be happy to answer any questions you have for me. Thank you.
Thank you, Shirley. Committee, do you have any questions for Shirley? Okay, I see that Carrie Johnson is here, and it looks like Lita's going to unmute her.
Yeah, Carrie, could you raise your hand again, please? All right, Carrie, go ahead and try to unmute.
Hello?
There you are.
Okay.
Go ahead, Carrie. Your 3 minutes will start now.
Okay, thank you. Is there too much background?
No, no background.
Okay, great. Thanks. Okay, I'm Carrie Johnson. I'm a pharmacist with Amgen Medical Affairs. Thank you for the opportunity to speak in support of Otezla or Prevalence. Reminders, Otezla was approved in 2014 for adult patients with active psoriatic arthritis and adult patients with moderate to severe plaque psoriasis who are candidates for phototherapy or systemic therapy. In July 2019, Otezla became the first FDA-approved therapy for oral ulcers associated with Behçet's disease. Warnings and precautions include diarrhea, nausea and vomiting, depression, and weight loss. Please see the full prescribing information for further details. I want to provide a few key reminders about Otezla. Otezla is an orally administered small molecule. It is not a biologic. It works intracellularly to inhibit phosphodiesterase 4, which results in an increase in cyclic adenosine monophosphate. This modulates the production of pro-inflammatory and anti-inflammatory cytokines. It's a very distinct mechanism of action. Importantly, when considering this class, Otezla has no black box warning, no warnings or precautions related to infection or malignancy, no laboratory monitoring or pre-medication screening requirements, and does not elicit the production of anti-drug antibodies, as it is not a protein. Otezla has fully published long-term safety data, 5 years in psoriatic arthritis and 3 years in moderate to severe psoriasis. I want to provide 3 updates, relatively recent updates. The first, in moderate to severe plaque psoriasis of the scalp, which is considered a difficult to treat area, causing a lot of quality of life issues for the patients that experience this, which is the majority of psoriasis patients at some course in their disease state. Otezla, 30 milligrams twice daily, demonstrated significantly greater improvements in scalp psoriasis, scalp and whole body itch, and quality of life compared to placebo during a 16-week double-blind placebo-controlled phase 3 study. It was a style study. These improvements were maintained in patients continuing Otezla out to 32 weeks. Most common adverse events through week 16 included diarrhea, nausea, and headache and vomiting. Most common adverse events out to week 32 were diarrhea and nausea. And these data are fully published and were added to the label in April of 2020 and represent an option for patients with scalp condition. Second, recent published analyses from claims data demonstrate that biologic naive patients with psoriatic arthritis who initiated Otezla had switch rates similar to biologic users and significantly lower healthcare costs, regardless of treatment switching. Thirdly, the Joint American Academy of Dermatology and National Psoriasis Foundation Guidelines for Care of Management of Psoriasis with Systemic Non-Biologic Therapies were just published in 2020 and recommend Otezla for the treatment of moderate to severe psoriasis in adults. In summary, Otezla is not a biologic, has no black box warning, has published long-term safety data. I would respectively ask the committee to consider adding Otezla to the PDL as an oral option for patients with active psoriatic arthritis and moderate to severe psoriasis. Thank you.
Thank you, Carrie. Committee members, do you have any questions for Carrie? And are there any stakeholders that did not get the opportunity to speak?
This is Lita. I do not see any other hands raised.
Okay, great. So we'll go to the motion for cytokine and CAM agents. Antagonists, excuse me. Committee members, if you're able to bring your cameras on so we can see one another.
This is Susan Plattabo. I move that all products in the cytokine and CAM antagonist drug class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class require prior authorization for medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Michael. I second the motion.
This is Virginia Bucola, Committee Chair. All those in favor, please say aye.
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 Are there any opposed? And the motion carries.
Ginny, this is Lita. Since we have a little bit of time before the break, can we go back to the Parkinson's motion?
Yeah, that'd be great. I was just going to ask about that.
This is Kavita Chavla. I move that all products in the antipsychotics, anti-manic agents, Parkinson's psychotic disorder drug class are considered safe and efficacious for their medically accepted indications and are eligible for their preferred status, and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, non-clinically appropriate, or only one product is preferred.
This is Nancy. I second that motion.
This is Virginia Bucola, Committee Chair. All those in favor, please say aye.
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 Are there any opposed? And the motion carries. And that brings us to a break.
This is Lita. Great, thank you. Let's take 10 minutes, so we'll come back at 10:51. And please mute your microphones on the break.
Hi, everybody. This is Virginia Bucola, Committee Chair. We're just reconvening after our break. And when Umang is ready, we're going to go to movement disorder agents.
Hi there, this is Umang. All right, so is it okay to go ahead and get started?
This is Virginia Umang. It's okay by me.
Okay.
Okay. Yeah, go ahead, Umang. Thank you.
Thank you. I just wanted to make sure. Okay, great. So the next class we'll be reviewing are movement disorder agents. Moving onward to the next slide. The first kind of subtopic that kind of encapsulates movement disorders is Huntington's disease. Chorea, an abnormal and involuntary twisting or writhing movement, is a characteristic feature of Huntington's disease, which is a rare and fatal genetic disorder resulting in neurodegeneration of the brain, which affects over 35,000 people in the US. As chorea becomes more severe, it can interfere with patients' function. As the disease progresses, chorea is replaced by dystonia and Parkinsonism. Chorea affects approximately 90% of patients with Huntington's, and it often develops early, gradually worsens, and plateaus in late stages. Symptoms may be aggravated by stress and anxiety. No current therapy exists to delay the onset of symptoms or prevent the progression of disease. However, symptomatic treatment may improve the quality of life and prevent complications. Xenazine, a VMAT2 inhibitor, was the first approved agent in 2008 by the FDA to treat chorea associated with Huntington's. A deuterated formulation allowing once daily dosing, or Austedo, was approved to treat chorea associated with Huntington's in 2017. Other therapeutic options that are used but lack FDA approval for this use, are known as off-label, include dopamine depleting agents and dopamine receptor antagonists. However, long-term use of these medications may carry a high risk of adverse effects. At the bottom here, you can see, according to the AAN, there is a guideline here that is about 9 years old, so I won't be reviewing it, but again, it is here for completeness sake. On the next slide, in terms of tardive dyskinesia, which is the second kind of subgroup that encapsulates under movement disorders, this consists of involuntary movements of the tongue, lips, face, trunk, and extremities that can occur in patients treated with medications with dopamine antagonist properties. It may consist of movements classified as bradykinesia or hyperkinesia. Dopamine transporter dysfunction and chronic central dopamine blockade have been hypothesized to play a role in the development of tardive dyskinesia, although multiple other pathophysiologic mechanisms have been proposed. Tardive dyskinesia differs from acute movement disorders, often referred to as extrapyramidal symptoms or EPS, which commonly occur in patients treated with dopamine antagonists. EPS most commonly occurs early in therapy and during dose increases. These acute movement disorders include akathisia, acute dystonia, Parkinsonism, and other hyperkinetic dyskinesias. Tardive dyskinesia generally occurs after long-term treatment with a dopamine antagonizing medication, but the timeline onset varies extensively. Once a patient develops tardive dyskinesia, it may be irreversible. And then on the next and final slide here for movement disorders, just in terms of clinical updates, there's a medication, Ingrezza, where in April 2021, FDA expanded the formulation to include 60 milligram capsule strengths. They was already available in 40 and 80 milligram. And in terms of indications, warnings, and dosage, it remains undeterred. For specialized populations, there is no dosage adjustment in this medication for renally impaired patients. And if patients are moderate to severely hepatically impaired, then there are dose adjustment recommendations. That is all for movement disorders. I'll pause right there for any questions from the committee.
Thanks, Umang. This is Virginia again. Any questions from the committee? Okay. We have several stakeholders, and I'll go ahead and list them now. If you don't hear your name called, please raise your hand or drop a message in the chat so that we know that you would like some time.
And Ginny, this is Lita.
Yes.
Again, when your name is called, if you can raise your hand so that I can easily unmute you, that would be helpful.
Thanks, Lita. We have John Dearson with Neurocrine. We have Jennifer Shear with Teva, William O'Neill with Synovian, Carrie Carroll with Telecare, Dr. Matthew Bogoyas with Comprehensive Healthcare in Yakima. And each, as I've said before, but just to reiterate, each presenter has 3 minutes. And at the beginning of your time, could you please acknowledge any affiliation you have with a pharmaceutical company, even if you're not employed directly by a pharmaceutical company. So that said, our first up is John Deason with Neurocrine.
This is Lita. John, I've unmuted you. If you can unmute yourself.
Good morning. Can you hear me okay?
Yes, we can. Go ahead. Your 3 minutes will start now.
Fantastic. Thank you. Hello, my name is John Deason, and I am a managed care liaison from Neurocrine Biosciences Medical Affairs Department, and appreciate the opportunity to speak to you today about Ingrezza, or generic valbenazine capsules, that's indicated for the treatment of adults with tardive dyskinesia, or TD. TD is an often persistent and disruptive condition associated with prolonged exposure to dopamine receptor blocking agents, including antipsychotic and antiemetic drugs. Recommendations from a recent systematic review include VMAT2 inhibitors as first-line treatment for TD, and in addition, the 2020 APA schizophrenia guidelines recommended VMAT2 inhibitors for the treatment of TD as well. Ingrezza has no box warnings and is only contraindicated in patients with a history of hypersensitivity to valbenazine or any of the components of Ingrezza, and has 3 warnings and precautions, including somnolence, potential for prolongation of QT interval, although the degree is not clinically significant at concentrations expected with recommended dosing, and Parkinsonism in patients with TD, with all 3 of these having been observed with other VMAT2 inhibitors as well. Now, the efficacy and safety of Ingrezza were established in multiple clinical trials in adults with TD and stable schizophrenia, schizoaffective disorder, or a mood disorder, with the most commonly reported adverse reaction greater than or equal to 5% and twice the rate of placebo being somnolence. Out of respect for the committee's time, I will refer you to the Ingrezza PI for a comprehensive overview of the clinical and safety data, and I'm happy to answer any questions that you may have. I would, although there's no direct head-to-head studies comparing Ingrezza or generic valbenazine and deutetrabenazine, there was a study using the Bucher indirect treatment comparison, or ITC method, that compared the efficacy and safety of valbenazine and deutetrabenazine that was recently published, where ITCs using pooled data for both valbenazine and deutetrabenazine randomized placebo-controlled trials displayed that regardless of the time point analyzed, the reductions in AIM scores favored the pooled valbenazine trials, where the differences in effects were statistically significant for comparisons of the pooled valbenazine time points versus the pooled deutetrabenazine time points, except for the 6-week valbenazine versus 12-week deutetrabenazine time point comparison. And this represented an additional AIMS reduction for valbenazine of 0.92 to 2 points. The analysis also showed no significant differences with regards to safety outcomes. So in summary, Ingrezza is an effective once-daily treatment for adults with TD with long-term safety and efficacy data up to 48 weeks. And I really appreciate the committee's time and respectfully request that the committee would add Ingrezza as a preferred agent to the PDL for the treatment of TD in adults. Thank you.
Thank you very much, John. Any questions from the committee for John? Okay, next is Jennifer Shear with TIVA.
Hello, can you hear me?
Yes, I can hear you. Go ahead.
Good morning. My name is Jennifer Shear. I am a medical outcomes liaison with Teva Pharmaceuticals, and today I'm here to provide information about Austedo, deutetrabenazine. Austedo is a VMAT2 inhibitor and is the only FDA-approved therapy indicated for the treatment of TD, or tardive dyskinesia, in adults and chorea associated with Huntington's disease. A box warning exists for the use of Austedo in patients with Huntington's disease. However, this warning is not associated with patients using Austedo for tardive dyskinesia. In December 2020, Austedo labeling was updated to reflect the following. At the maximum recommended dose, Austedo does not prolong the QT interval to any clinically relevant extent. Labeling no longer requires assessment of the QT interval before and after increasing the dose of Austedo to greater than 24 milligram in patients who are at risk of QT prolongation or in patients using other drugs to known to prolong QT. In TD patients, the most common adverse reactions occurring in greater than 3% of Austedo-treated patients and greater than placebo were nasopharyngitis and insomnia. In patients with HD, the most common adverse events occurring in greater than 8% of Austedo-treated patients were somnolence, diarrhea, dry mouth, and fatigue. Compared with tetrabenazine, deutetrabenazine was associated with significantly lower risk of moderate to severe adverse events and neuropsychiatric adverse events, including agitation, akathisia, depression, drowsiness, somnolence, insomnia, and Parkinsonism. Austedo provides response-driven dosing options with 6 mg, 9 mg, and 12 mg oral tablets, administered total daily doses of 12 mg or above in 2 divided doses. In analysis based on real-world data, the mean daily dose of Austedo was determined to be 25.6 mg and 28.5 mg in TD and HD, respectively. The REM-TD study is an ongoing 3-year open-label extension study to evaluate the long-term safety and efficacy of Austedo in patients with TD. 343 patients were titrated using response-driven dosing up to 48 mg a day, and patients treated with Austedo experienced sustained improvements in AIM score over time with a mean change in AIM score of -6.6 at week 145. And the percentage of patients who achieved 50% or greater and 70% or greater improvements in AIM score from baseline increased over time, with the majority of patients, 67%, experiencing 50% or greater improvement by week 145. 73% of patients achieved treatment success based on the CGIC. And deutetrabenazine was generally well tolerated across 723 patient years of exposure through week 158. And this concludes my comment today. I thank you for your time, and I'm happy to answer any additional or any questions from the committee.
Thank you very much, Jennifer. Are there any questions? Okay, next is William O'Neill with Synovian.
Hi, Virginia and Lita. I think that our impression was that under this movement disorder, there would be some inclusion of the anti-Parkinson's products. And so if that's not the case, I didn't want to waste the committee's time by giving my testimony. So if you can confirm that that's an inappropriate topic for this particular subject, then I'll just give my time back.
Well, let me ask Lita. And what agent were you going to speak to?
Kinmobi.
Okay, I don't know. I'll turn that over to Lita. Question.
Okay, Umang, that was not a drug under movement disorder agents, correct?
Could you repeat the drug name, Lita?
Or William, can you repeat it?
Yes, it's Kinmobi.
I don't believe so.
It's to treat off episodes in Parkinson's disease.
Okay. Then Lita, I would go ahead and class that under here.
Okay. William, go ahead.
Oh, okay. Thank you. Well, thanks for the opportunity to speak. I am here talking on behalf of Kinmobi. Currently, Kinmobi is a non-preferred and subject to a prior authorization with approval criteria requiring a trial and failure of 2 preferred products with the same indication. So Kinmobi is a sublingual film indicated for the acute intermittent treatment of off episodes in patients with Parkinson's disease. This indication is distinctly different from other dopamine agonists, which have the same mechanism of action but different indications. You can think of Kinmobi as an on-demand treatment or a rescue when Parkinson's patients are experiencing particularly troublesome off episodes, which can include different combinations of actually several types of off episodes, like morning offs, when patients wake in the morning with virtually no blood levels of the medication they took the night before and are having trouble getting started in the morning. Delayed ons, which is the delay between the time the patient takes their medication and when they start to receive satisfactory improvement in their motor symptoms. The wearing offs, which is the predictable occurrence of patient motor symptoms before the next scheduled dose of medication. And then, of course, unpredictable offs is when a patient randomly and abruptly transitions from an on to an off state. Of these off episodes, morning offs and unpredictable offs tend to be the most troubling to Parkinson's patients. Morning offs tend to be very deep. They can delay getting out of bed, the ability to use the bathroom, and simple things like changing clothes. All of these types of off episodes can be treated with an on-demand therapy such as Kinmobi. However, not all off episodes can effectively be treated with current adjunctive treatments, which can extend on time but cannot move a patient from off to on. We would like the committee to consider moving Kinmobi to preferred status with the trial and failure of levodopa-carbidopa, and we would suggest the committee have a separate on-demand category under movement disorder agents. Forcing a patient to step through an on-extender when they really need an on-demand agent only opens the patient up to increased risk for side effects, increased cost to the patient and the plan, and doesn't actually resolve the problem that the patient is experiencing. Neurologists do a good job of interviewing their patients around the type of off episodes they are experiencing and know which treatments to prescribe. So due to the progressive nature of Parkinson's disease in some Parkinson's patients, it may be necessary over the course of treatment to need carbidopa-levodopa, an on-demand treatment, and an on-extender all at the same time to control their motor symptoms. So our ask is that we just please create a criteria that allows the neurologist the opportunity to choose the order in which they add medications to their patient's drug regimen. And again, thank you for the time to speak today. And if you have any questions, I'd be happy to answer those.
Thank you, William. Any questions? Okay, and to Carrie Carroll with Telecare.
This is Lita. Again, if you can raise your hand. All right, Carrie, I have unmuted you. She's not responding. Maybe she stepped away. Let's go to Matthew Bogo. Yes. Okay, Matthew, I've unmuted you. If you can unmute yourself. Matthew, can you unmute yourself? Okay, I don't know if he's, let me see. Matthew, if you're having trouble unmuting, if you could type something in the chat. See, he's lowered his hand. Okay, wait, no, he's back.
He's back up.
Okay. So your mic is enabled. If you can unmute yourself, Matthew. Oh, he's having some issues. Okay, let me just try it one more time. Here, I'll disable and allow again. Matthew, are you able to unmute yourself now? Yeah, we still can't hear you.
Give it one more try, Matthew. I think your mute got a little bit switched up in there. Your mute button should be about 2 buttons to the left of the leave button. It looks like a little microphone.
Okay, we still can't hear you, Matthew. Maybe are you able to type your comment in the chat?
This is Ginny. Lita, I'm just curious. I wondered to give Matthew enough time to type his comments, and if Carrie's able to hear us, if she's able to type her comments, could we go to ophthalmic agents and then come back to the motion, or is that too broken?
Let's see, Carrie, if you would like to speak, please raise your hand. Carrie Carroll. Okay. Okay.
Lita, are you looking for Carrie Carroll?
No, I asked her to raise her hand because she didn't unmute before, so she may have walked away for right now. So unless she raises her hand, I don't think she's on right now.
Perfect.
Just looking at now if I guess Matthew's typing his comment.
Here we go.
Okay, thank you.
Yeah. So I just want to be sure that the committee is able to read his comment. And if there's any questions after that comment, that we could put them in the chat or unmute.
Yeah, this is Lita. I can read it out loud just so
Okay,
it's
thank
on
you.
record.
Okay, thank you.
So Matthew Bogoyas has said, I've worked with both of these agents that have been discussed, Austedo and Ingrezza. Both work well in helping patients with TD, but there are some issues I've noticed working at Comprehensive Mental Health Center as the medical director.
I'm wondering if this is Virginia. I wonder if that's an incomplete comment. I don't know, Matthew. Maybe you can raise your hand if there is more coming, or if that's, okay, thank you. His hand is raised.
Okay. Okay, so Matthew has said, I've used both of these agents, but there are some advantages to Ingrezza in regards to Austedo. Austedo has a dose titration that is difficult for many patients. It also requires twice daily dosing. If the patient stops Austedo for more than a week, you need to retitrate. Previously, I worked in Florida where Austedo and Ingrezza were the same level of preferred. I think it would be nice to consider both of these agents at the same level as they both work well. Okay, and Matthew, when you're done with your testimony, if you could just type end so that we know that you're done. But most of our psychiatric clients do well on Ingrezza because it begins working with one dose and doesn't require a difficult increase in dose. I have no drug company affiliation. I am happy to answer questions. Sorry, the mic isn't working. End.
Thank you, Matthew. Committee members, do you have any questions for Matthew? Okay, looks like we can go to the motion.
This is Leah Marcotte. I move that all products in the movement disorder agents drug class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class require prior authorization for medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred. And can I just clarify one thing actually before? Usually it says products in this class may require prior authorization. Is this class all products require? Is that accurate that all products require prior auth?
Hi, Leah, this is Marissa. Yeah, so in this class, all the products have a prior authorization on them.
Okay, that sounds good. I just wanted to make sure that that was accurate before moving on.
This is Jordan Storhaug. I second.
This is Virginia Bucola, Committee Chair. All those in favor, please say aye.
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 Are there any opposed? And the motion carries. And that takes us to ophthalmic agents. Whenever you're ready, Umang.
Perfect. Thank you. This is Umang. Next, we have ophthalmic agents. Just a quick note for the committee. The next 2 topics are going to be under, I believe, one motion, which is the ophthalmic agents. So I will be going through glaucoma agents and then immediately into immunomodulator agents, where I will pause for the committee. On the next slide here, for glaucoma agents, a little bit of background. Approximately 2.7 million people in the U.S. suffer from glaucoma. It is the second most common cause of permanent blindness in the U.S. and most common cause of blindness among African Americans and Hispanics. Risk factors for the development of glaucoma include elevated intraocular pressure, advancing age defined as greater than 40 years, family history of glaucoma, and African American or Hispanic descent. Increased intraocular pressure is common in glaucoma and is believed to contribute to the damage to the optic nerve, which can lead to the loss of visual sensitivity and field. However, some patients with glaucoma have normal IOP, and many patients with elevated IOP do not have glaucoma. It alone is no longer considered a diagnostic criterion for glaucoma. 2 major types of glaucoma have been identified as open angle and closed angle. In open angle, there's reduced flow through the trabecular meshwork. Open angle glaucoma accounts for the majority of cases. In closed angle, the iris is pushed forward against the trabecular meshwork, blocking fluid from escaping. Reduction of IOP may be achieved either by decreasing the rate of production of aqueous humor or increasing the rate of outflow of aqueous humor from the anterior chamber of the eye. Topical ocular hypotensive agents can delay or prevent the development of primary open angle glaucoma in some patients. On the next slide here, we do have guidelines for glaucoma agents, the first being American Academy of Ophthalmology in 2018, and the next an update for 2020. Normally, I wouldn't go over the ones that are greater than a year, but because they're from the same academy, I'm going to for completeness sake here. The goal of treatment is to maintain the IOP in a range at which loss of visual field is unlikely to significantly affect a patient's health-related quality of life over their lifetime. An initial target pressure is at least 25% lower than pre-treatment IOP. However, target pressure is an estimate and should be individualized based on disease course. Lower IOP targets are reasonable in patients with more severe optic nerve damage. Medical therapy is the most common initial intervention to lower IOP. Medication classes used in the management of glaucoma include beta blockers, miotics, sympathomimetics, topical and oral carbonic anhydrase inhibitors, and prostaglandin F2 analogs. Monotherapy or combination therapy may be used to treat glaucoma and delay the need for surgery and prevent functional vision loss. At an update in 2020 by the same academy, preferred practice patterns, prostaglandin analogs are the most frequently prescribed eye drops to lower IOP due to their efficacy, safety profile, and once daily regimen. Sufficient management of glaucoma is dependent on a high level of adherence to therapy. Data has suggested the addition of a second medication can lead to reduced adherence. Therefore, fixed dose combinations may potentially increase adherence and decrease exposure to preservatives. Although fixed dose combinations are not usually recommended as initial therapy, a fixed dose combination agent may be warranted in patients requiring a greater IOP reduction than available with a single agent. On the next slide, in terms of clinical updates for the medications under glaucoma agents, there was a discontinuation notice here. For phospholin iodide in October 2020, the FDA announced the discontinuation of this medication and 6.25 milligram package. Pfizer expects the product will remain available through May 1st, 2021. In terms of a new generic, brinzolamide in December 2020, the FDA approved the first generic for Novartis's Azopt medication. That concludes the glaucoma agents. I'll continue forward with immunomodulators. For the ophthalmic agents, immunomodulators, a little bit of background here for keratoconjunctivitis sicca. KCS is defined as dry eye disease related to either decreased tear volume, aqueous tear deficiency, or rapid evaporative loss and evaporative tear deficiency due to poor tear quality. Both of these conditions may be present in dry eye syndrome. The term dry eye syndrome, dry eye disease, keratoconjunctivitis sicca, or keratitis sicca are often used interchangeably, with the term keratoconjunctivitis sicca being an older term. There is considerable overlap with other ophthalmic conditions such as meibomian gland dysfunction. DES or KCS affects approximately 10 to 30% of the US population and occurs more commonly in patients over 50 years of age, with approximately twice as many women as men affected. However, due to increased use of soft contact lenses and frequent smartphone and computer usage, the prevalence of DES is increasing among young adults aged 18 to 34 years of age. Patients with KCS and DES may have the following complaints: sensation of ocular dryness, grittiness, a foreign body or irritation, hyperemia, mucoid discharge, excessive tearing, photophobia, and blurry vision. On the next slide here, for updates to clinical information in medications, in October 2020, FDA approved Isuvius, and this is a corticosteroid indicated for the short term, defined as up to 2 weeks, treatment of signs and symptoms of dry eye disease. In terms of warnings and precautions, it is contraindicated in most viral disease of the cornea and conjunctiva, including epithelial herpes simplex keratitis, vaccina, and varicella, and also in mycobacterial infections of the eye and fungal diseases of ocular structures. There is a delayed healing in corneal perforation. The initial prescription and each renewal of the medication order should be made by physician only after examination of the patient with the aid of magnification, such as slit lamp biomicroscopy, and where appropriate, fluorescent staining. And lastly, prolonged use of corticosteroid may result in glaucoma with damage to the optic nerve, defects in visual acuity and fields of vision. Renewal of the medication order should be made by physician only after examination of the patient and evaluation of the IOP. For dosing, it is simply 1 to 2 drops into each eye 4 times daily, and the availability, as you can imagine, is an ophthalmic solution containing 2.5 milligrams per milliliter of said medication. On the next and final slide for immunomodulators, we have Verkasia, and in June 2021, the FDA approved Verkasia, which was a calcineurin inhibitor immunosuppressant for the treatment of vernal keratoconjunctivitis in children and adults. In terms of warnings and precautions, to avoid the potential for eye injury and contamination, advise patients not to touch the vial tip to the eye or other surfaces. It is 1 drop 4 times daily, and they define that morning, noon, afternoon, and evening in each affected eye. And as you can imagine, it is an ophthalmic emulsion, and so it's 0.1% cyclosporin. Go ahead and pause there, and just remind the committee that both glaucoma and immunomodulators will be under ophthalmic agents.
Thanks, Suman, for that reminder. We have one stakeholder, and that is Margaret Ullman with AbbVie. If there are any other stakeholders, can you please raise your hand or write your name in the chat so we know you're here? And I see that Margaret's hand is raised already.
Hi, can you hear me okay?
Yes, I can hear you. Thank you, Margaret. Go ahead.
Hello, I'm Dr. Margaret Ullman, still with Medical Affairs at AbbVie. Thank you for the opportunity to talk with you today about Lumigan, the brand name for bimatoprost, 0.01% ophthalmic solution. Open-angle glaucoma, a chronic progressive disease, is the leading cause of irreversible total vision field blindness. So far, the only approach proven to be effective in preserving visual function is lowering interocular pressure. Every millimeter of mercury elevation translates to a 19% increased risk of progression of disease. No single IOP level is ideal for every patient. Guidelines recommend each patient's treatment be individualized. Lumigan is a prostaglandin analog indicated for the reduction of elevated interocular pressure in patients with open-angle glaucoma or ocular hypertension. I'd like to highlight 3 important points about Lumigan for you. First, Lumigan has 2 modes of action, unlike other prostaglandin analogs such as latanoprost. While the precise mechanism of action is not fully characterized, it is believed to lower interocular pressure by increasing outflow of aqueous humor through both the trabecular meshwork and uveoscleral roots. Acting in this way, Lumigan selectively mimics the effects of naturally occurring prostamides. Second, I would like to bring your attention to a comparison of Lumigan 0.01% solution with bimatoprost 0.03% drops in a study by Katz and Associates. Lumigan, with its lower concentration, produced equitable IOP lowering effectiveness across the 12 months of this study while cutting the treatment-related adverse events by 1/3. The discontinuation over time due to ocular adverse events was also significantly lower with the Lumigan arm. Lastly, Lumigan may work in patients who do not respond to other prostaglandin analogs. I'd like to share information from a study by Myers and Associates. For patients previously treated with latanoprost and switched to Lumigan, a lowering of an additional 4 millimeters of mercury was observed. Switching within this class may be valuable for patients who are not reaching their treatment goal with their initial therapy. The most common adverse events of Lumigan were conjunctival hyperemia in the pivotal study. Approximately 1.6% of patients discontinued therapy for this reason. For comprehensive safety and efficacy data, please see the full prescribing information at rxabbvie.com. I want to close by respectfully asking that Lumigan 0.01% solution be considered as a preferred option for Washington Medicaid patients, and I'd be happy to answer any questions you might have at this time.
Thank you, Margaret. Are there any questions from the committee? Okay, so we're going to go to the motion. And again, this is one motion for 2 presentations.
This is Michael Corsilis. I move that all products in the drug classes listed on slide 11 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Alex Park seconding that motion.
This is Virginia Bucola, Committee Chair. All those in favor, please say aye.
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 Are there any opposed? And the motion carries. And we go to respiratory agents next.
This is Umang. Perfect. Thank you. So this is a quick one, this topic. As I mentioned earlier, if I include pertinent, significant clinical information or updates in the last year. And for this subclass, there were no clinical updates. And so I'll pause right there for the committee.
Thanks, Umang. Hang on, we have one stakeholder for respiratory agents, and that's Michael Horton with Boehringer Ingelheim. Michael, can you raise your hand if you're here?
This is Lita. Michael, I've allowed you to use your mic if you can unmute.
My apologies. You'd think by this point in 2021 I would remember to unmute, but thank you nonetheless. Thank you to the committee for allowing me a few minutes to address this. The only thing I would add, since he did not offer any additional comments, and I can't remember if this was covered last year, is just to point out that with nintedanib, we actually do have 3 approved indications. All 3 were based on very robust phase 3 trials. The 2 additional ones were, of course, in systemic sclerosis ILD, and then the chronic fibrosing ILD with a progressive phenotype. And so I just wanted to make sure everybody was aware of that. And I really have nothing else to add unless there are any other questions. And if there are not, I will give back this time to the committee.
Thank you, Michael. Are there any questions? Okay, we can go ahead and look at the motion for respiratory agents.
Hi, Ginny. Kavita Chawla here. I'm just wondering, how do we decide, like for some of these, as Leah had pointed out earlier, some of them require, like all agents will require prior auth versus other ones, they may require prior auth. Is this a decision that HCA makes in a separate setting?
I don't know if I can address the question as to how, what the history is in terms of what's presented to us. But I know that we can, as a committee, discuss if there's any language changes we'd like to make in the motion.
Hi, Ginny. This is Donna. So the language that the way we say may is it gives it it's more permissive for HCA to, at our own discretion, put it on prior authorization or not put it on prior authorization. If you want, if you think that there are drugs that should not be on prior auth, or we can discuss what that might look like if we were to remove it. And typically we try to get policies developed as soon as possible when they are on PA, and we bring those to the board for review.
Thanks, Donna. Kavita, does that help to clarify that for you?
Yes, it does. I suppose like when we're looking at the language here, we're not really addressing any specific agents to call them out for they should or should not be under prior auth. This is more just a group of agents discussion, right? And then if we do a separate policy discussion, then maybe there it is up for discussion. Not sure I'm making myself very clear.
I think you're clear. I'm understanding what you're asking. That's my interpretation also. So if there's any clarification, Donna, that needs to come from you, we're all ears.
I was just messaging. I just noticed that this kind of is missing some of our standard language that we talk about the preferred have to try and fail, and that they may require prior auth. Is the question more about why is this motion different than the others that you've currently read? And should it be more similar to the others?
No, my question was in general, when we make, you brought up earlier that the language in these motions is up for discussion at these meetings. And I was trying to sort out when it's an individual level, an individual drug level discussion, is that at this part of the meeting, or is that when we are discussing specific policies for the drugs?
I think you can do it at any time. It really probably depends what you're trying to accomplish. Like if you feel there's evidence that shows a drug clearly is superior to another and you want it to be preferred, you could, say that. Or if there's a drug that that clearly has a safety concern or, an adverse event profile that you would want it to not be a preferred drug, you could say that as well. Or you can be, more deferential, and we will make that, we can make those decisions. What we do now is this is more, I would say, permissive information. And then what we do is we, look at our utilization, we look at the net cost for the drugs, and based on your, recommendation, we will then, choose the preferred products after the, the committee makes their recommendation.
Okay, that is helpful. Yeah, I think those are my questions for now.
Great, thank you.
Donna, could I just clarify to your earlier question? Why is this motion much shorter than usual?
I think that was just an oversight on our part, and that we should probably go back to one of the other motions and copy and paste that additional information and put it in here.
Hi, Lita, this is Marissa. Yeah, it would be just that section right there. I apologize for that oversight.
This is Alex Park. Donna, I was just looking at the Excel sheet that got sent out with the PDL. I think all the agents, well, there are only 2 drugs in this class, and they are all preferred. Is that right?
I would have to double check.
Hi, Alex, this is Marissa. Yeah, I can confirm that's correct. There's only 2 agents, and they're both preferred in this class with PA.
Kavita, did you have a concern about one or the other drug, in terms of feeling that one shouldn't be preferred, or?
No, the timing of my question does not have anything to do with this particular class of agents. I was trying to understand just the protocol of when a discussion is to be had, because I know there's also that difference between like the HCA P&T and then the DUR part. And so this is actually more rumination about some of the other drug classes that we did approve. I believe one of them was anti-Parkinson's medications, where the language did say that all medications require a pre-auth. And so in my mind, I was trying to figure out why would all of those agents require pre-auth while other ones may require a pre-auth. So I was trying to understand the protocol here and when does it get discussed one way or the other.
And Kavita, this is Donna again. I would say that that particular motion probably should have said may and not all.
That would make me feel more comfortable too, because for those patients, I don't know what their option would be if everything is pre-auth.
I don't know. I'm not sure if that's even an accurate statement to say that they all require prior authorization. I'd have to go back and look at the particular drug class, unless it was a subclass and there was only the one drug in it.
I think that was for movement disorders class.
Okay.
Okay, so this is Lita. What do you want me to remove?
Nothing on this slide.
Oh, okay.
All right, I'll go ahead. I move that all products in their respiratory agents, pulmonary fibrosing agents, drug class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Lita. I couldn't hear who seconded.
Yes, sorry.
Leah?
Oh, yeah. I'm sorry, I didn't hear it either. This is Virginia Committee Chair. All those in favor, please say aye.
Aye.
Aye. Are there any opposed? And the motion carries. Do we need to return to the movement disorder agent motion and correct language before we go forward?
That would be helpful, yeah.
Okay.
Okay, can you tell me what the change is? Is it about prior auth?
Just put may require prior authorization.
And I made that motion. Can I just say agree with edits and correction that the class may require prior authorization?
Thank you, Leah. Any opposed to the change in that language? Okay. Lita, not to rush ahead, but I'm wondering, should we go ahead and do smoking deterrence before lunch?
Yeah, we can do that.
Okay. If everybody is okay with that.
Ginny, did the opioid agents also have required prior auth?
Gosh, I don't know. But,
no, that was incorrect. Sorry.
If you want, Jenny, if you want, we can go back through, with your approval and direction and make sure that they all say may, so that we don't have to go back and redo each particular motion. If that's okay,
that would be great.
Okay.
That would be great. I think, and thanks to Kavita for noticing that wasn't consistent.
May require. So yeah, it looks like it was just a couple of them didn't have may in there.
Okay.
Thank you.
Yeah, no, thanks again, Kavita.
Umang, are you on?
Yes, I am.
Okay, great.
Sorry. I wasn't sure if there was still some tinkering with the motions or not. Okay. Next, this is Umang. Next, we'll go over to smoking deterrence. On the next slide here, smoking cessation agents. Cigarette smoking is the leading preventable cause of death and is responsible for about 1 in 5 deaths annually, or about 480,000 deaths per year in the United States. Approximately 70% of smokers have a desire to quit completely, and 55% have made a quit attempt in the last year. Discontinuing smoking often requires multiple attempts. Most attempts aren't successful because they are unaided, Relapse is often caused by stress, weight gain, and withdrawal symptoms. And examples of common nicotine withdrawal symptoms include irritability, anxiety, difficulty concentrating, and increased appetite. According to the American Thoracic Society last year, they published new clinical practice guidelines on initiation of pharmacotherapy for tobacco dependence in adults. The guidance maintains all patients who are using tobacco should receive treatment for dependence and not only be encouraged to discontinue tobacco use. Strong recommendations in the guidelines include preference for use of for Chantix over a nicotine patch, preference for Chantix over bupropion, use of Chantix rather than a nicotine patch in adults with comorbid psychiatric conditions, starting Chantix in adults even if they are not ready to quit, and using controller therapy for an extended duration of more than 12 weeks. Conditional recommendations include the combination of nicotine patch with Chantix over use of Chantix alone, and use of Chantix over electronic e-cigs, electronic cigarettes. On the next slide, the U.S. Preventative Services Task Force this year recommended that clinicians ask all adults about tobacco use and to advise current users to stop using tobacco and provide behavioral interventions, including approved pharmacotherapy for tobacco use cessation. And this was a level A recommendation. Clinicians should also advise pregnant women to stop using tobacco and provide behavioral interventions. However, evidence is not sufficient to assess benefits versus risk of pharmacotherapy use in pregnant women. In April 2020, the USPSTF issued a recommendation for school-aged children and adolescents who have not started to use tobacco, stating that primary care clinicians are recommended to provide interventions such as education or brief counseling in order to prevent tobacco use initiation in these individuals. However, for school-aged children and adolescents who use tobacco, it was concluded the current evidence is inadequate to determine the benefits versus risks of primary care feasible interventions regarding tobacco cessation. That is the only update in this class due to the 2 new guidelines within the last 12 months. I wanted to highlight those. There is no drug-specific clinical update in the last year, so I'll go ahead and pause there for the committee.
Thanks, Umang. We don't have any stakeholders unless there is somebody that has not signed up. I also want to take a moment. I don't think I asked specifically after the last 2 topics if there were any stakeholders that were waiting to be heard and were not recognized. Okay, I don't hear or see anybody, so we can go to the motion.
Ginny, I just had a quick question for Umang.
Go for it.
Does the USPSTF guideline specify a preference of Chantix versus Wellbutrin for the treatment of smoking cessation?
No, that the update was primarily around more so prevention. So the 2021 update was just about that, not about treatment options.
Thank you.
All right, hang on. Technical difficulty. Okay.
This is Catherine Brown. I move that all products in the smoking deterrence, miscellaneous, other drug class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Nancy. I second that motion.
This is Virginia Bucola, Committee Chair. All those in favor, please say aye.
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 Are there any opposed? And the motion carries. And that looks like that brings us to a lunch break.
This is Lita. Yes, let's take half an hour.
Okay, thank you.
Right, so we will return at 12:20. Please mute your microphones while on break. Hi, Umang. This is Lita. We'll just wait for Ginny to return.
Sounds good.
Hi, this is Lita. Ginny, I want to see if the committee is back. Hi, Kavita. Okay, great. Thank you, guys. Okay. Okay, we have a quorum, so why don't we get going? And Jordan, if Ginny isn't back by time we're ready for stakeholders, et cetera, I'll have you lead. All right, go ahead, Umang.
Perfect. This is Umang Patel. We'll go ahead and get started with the next subclasses. Just to inform the committee, essentially what will be happening for the next kind of part, as you can see, the next and final part of my clinical presentation has a lot of different subcategories for oncology medications. Previously, I mentioned how Magellan's therapeutic classes in Washington states isn't always a one-to-one. Ours are sometimes broken down by systems of oncology, for example, prostate, breast cancer, renal cell carcinoma, et cetera. I believe on the Apple Health PDL, it is by mechanism of action. And as one can imagine, one medication that has a certain mechanism of action can be used for different oncology, different cancers. And so I will be going over all oncology agents with the mechanism of actions that are listed here. And we will be doing the motion, I believe, at the end. And Lita and or Marissa, please correct me if I'm wrong on that.
This is Lita. You're correct. We will have one.
Perfect. Alrighty. So the first class we'll be looking at is prostate cancer. This encompasses the androgen biosynthesis inhibitor and the anti-androgens, both oral medications. On the next slide here, a little bit of overview. In the United States, prostate cancer is the most commonly diagnosed cancer in men, excluding non-melanoma skin cancer, with an estimated of a little bit short of 200,000 cases projected to be diagnosed in 2020. While prostate cancer accounts for the largest percentage of diagnosed cases in the US, roughly 20% of males, it only accounts for about 10% of all cancer deaths in this population, far behind lung cancer, the leading cause of cancer death, which accounts for 24% of US male cancer deaths. Prostate cancer is rare in men under the age of 40 years, but the risk increases with each subsequent decade of life. Overall, 1 in 9 US men will develop prostate cancer during their lifetime. Aside from age, the risk factors most strongly associated with the development of prostate cancer include race, ethnicity, and family history. Prostate cancer mortality in non-Hispanic African Americans is more than twice than that of in the US Caucasian population. And prostate cancer may represent an indolent disease in some patients with a highly aggressive disease in others. On the next slide here, we have an overview, continuing on for the overview. Androgens, specifically testosterone, are a known growth signal for prostate cancer, and the majority of prostate cancers are hormonally dependent. Due to the hormone responsiveness of the tumor, androgen deprivation therapy, ADT, is a cornerstone of prostate cancer treatment. ADT is utilized as the backbone of therapy in advanced or metastatic disease, as well as in combination with radiation therapy for clinically localized disease. ADT can be accomplished by utilizing either a surgical approach, bilateral orchiectomy, or a medical approach with the administration of a luteinizing hormone-releasing hormone agonist or an LHRH antagonist to suppress the serum testosterone concentrations to castrate levels, defined as less than 50 nanograms per deciliter. IV chemotherapy options such as docetaxel and Jevtana, as well as immunotherapy options for certain patients include Provenge or Keytruda, and a radiopharmaceutical option, Xofigo, may be utilized in the treatment of metastatic prostate cancer. Additionally, the use of oral polymerase inhibitors in select prostate cancer patients is included in a separate TCR. The use of docetaxel, cabazitaxel, Provenge, Keytruda, and radium-223 for the management of metastatic prostate cancer is beyond the scope of this review and will not be discussed in that. Again, it's specifically for the sub-mechanism of actions. On the next slide here, we have Xtandi, and I apologize if for some of my pronunciations here. In August 2020, FDA approved a new tablet formulation of Xtandi in 40 milligrams and 80 milligram strengths. Like the previously approved 40 milligram capsule, it is approved for the treatment of patients with castration-resistant prostate cancer and metastatic castration-sensitive prostate cancer. Again, it is just a new tablet formulation, so it was just 40 and 80 milligram tablets. It already is here available in 40 milligram capsules. On the next slide, in December 2020, FDA approved Orgovyx, which is a GnRH receptor antagonist indicated in the treatment of adult patients with advanced prostate cancer. It does carry some warnings with it, first being a QTc interval prolongation. So it is important to monitor a patient's QT interval along with monitoring for any other medications that may increase QT interval. And the second being embryo-fetal toxicity. This can cause fetal harm and loss of pregnancy. Advise males with female partners of reproductive potential to use effective contraception. The dosing for this is a loading dose of 360 milligrams on the first day of treatment, followed by 120 milligrams taken orally once daily at approximately the same time each day. And it is, again, in tablet form of 120 milligrams. This medication is not, there's no recommendations for renal or hepatic impairment. And as I mentioned before, we'll just be kind of going over all oncology medications, and then the final vote will occur. Motion. On the next slide, we have oncology oral, and this is specific to hematologics. And I will define what medications break down into this. So for hematologics, as one can imagine, there are various cancer types that fall under this. The first being marginal zone lymphoma. MZL accounts for approximately 10% of all NHLs and are generally divided into three subtypes: nodal MZL, splenic MZL, and the most common subtype, mucosa-associated lymphoid tissue. Lenalidomide plus rituximab is an NCCN Category 2B as in beta recommendation for the first-line therapy of MZLs. For elderly or infirm patient, chlorambucil with or without rituximab may also be utilized in the first-line setting. Both lenalidomide with or without rituximab and ibrutinib as a single agent are NCCN for V4 2020 Category 2A preferred recommendation for second and subsequent line therapy of MZL. Idelalisib or duvelisib may be used in second and subsequent line of marginal zone lymphoma in patients who are relapsed refractory after 2 prior therapies. The next being acute myeloid leukemia or AML. Most common form of acute leukemia among adults, estimated 5,930 cases diagnosed and 1,500 deaths in the US in 2019. In patients who obtain a CR, 3-year survival is 45%. Remission rates are inversely proportional to age. Cytogenetics does play a large role in determining prognosis and treatment options. And acute promyelocytic leukemia is a subtype of AML with distinct features and treatment. For the third subcancer type, we have diffuse large B-cell lymphoma. DLBCL are the most common types of lymphoma and account for 30% of all NHL. There are several subtypes of DLBCL, including DLBCL arising from follicular lymphoma. Some patients with follicular lymphoma may undergo conversion to more aggressive lymphomas, such as DLBCL, and this risk increases over time. About 30% of follicular lymphoma patients convert to more aggressive lymphoma at 10 years post follicular lymphoma diagnosis. The B-cell lymphoma NCCN guidelines list Expovio as an option for DLBCL not otherwise specified, including DLBCL arising from follicular lymphoma after at least 2 prior systemic therapies. On the next slide, we have the fourth and final subtype, and as the committee may remember, I tried to encompass the relevant background disease states for the new clinical updates in this section. So the fourth disease state we have is Kaposi sarcoma. It is a malignancy of the endothelial cells and is characterized by cutaneous red or brown papules, often seen on the lower extremities. There are 4 types. Classic presents with cutaneous lesions, but follows an indolent course. It is most common in elderly patients of Mediterranean, Eastern European, Middle Eastern, and or Jewish descent. Endemic Kaposi sarcoma tends to be more aggressive than classic and occurs in younger patients less than 40 years of age, as well as children in equatorial Africa. The third type is iatrogenic and occurs in the setting of patients taking immunosuppressive therapies, such as organ transplant recipients. And the fourth and final subtype is seen in patients infected with HIV. In these patients, Kaposi sarcoma is considered to be an AIDS-defining cancer. The risk for developing Kaposi sarcoma is estimated to be approximately 498-fold higher in HIV-positive patients compared to the general U.S. population. Due to the improved treatment options available to AIDS patients, the incidence of this cancer has been declining. The NCCN 2020 guidelines for AIDS-related Kaposi sarcoma list Pomalyst as a preferred systemic therapy option for patients with relapsed refractory disease, and note that Pomalyst has been FDA approved for the treatment of adult patients with AIDS-related Kaposi sarcoma after failure of highly active antiretroviral therapy. On the next slide here, we have guidelines from the American Society of Hematology from last year. They published guidelines for the treatment of newly diagnosed AML in older adults. The guideline examined questions around the role of treatment for adults with AML and the intensity and length of treatment in this patient population. The general conclusion of the panel of experts was that for older adults, treatment is recommended over best supportive care, and more intensive therapy is recommended over less intensive therapy when it is tolerable to the patient. Specific recommendations pertaining to patients who are not appropriate for intensive anti-leukemic therapy, but who are able to receive treatment include a recommendation of monotherapy over combination therapy. And lastly, the guidelines further note that when these patients choose combination therapy, there's evidence to support the use LDAC in combination with venetoclax. Okay, so on the next slide here, we have the subclasses by Apple Health Organization. And so for this, we have anti-neoplastic miscellaneous combination, and that includes INCOVI. We have hedgehog pathway inhibitors oral, and that includes Durissimo. Multi-kinase inhibitors oral, and that would be Rydapt or Uconic. TKIs, tyrosine kinase inhibitors, and that has Bosulif, Brukinza, Gleevec, Iclusig, Imatinib, Imbruvica, Sprycel, Tasigna, and Zospata. And lastly, retinoids are oral, which is tretinoin. Of these, the ones I have bolded are the ones that do have recent updated clinical information that I'll be sharing with the committee. So the first of 3 will be INCOVI. On the next slide, in August 2020, FDA approved INCOVI, a combination decitabine, which is a nucleoside metabolic inhibitor, and citazaridine, which is a cytidine deaminase inhibitor, indicated for the treatment of adult patients with myelodysplastic syndrome, MDS, including previously treated and untreated de novo and secondary MDS, with the following French, American, British subtypes: refractory anemia with ringed sideroblasts, refractory anemia with excess blasts, and chronic myelomonocytic leukemia, and intermediate 1, 2, and high-risk international prognostic scoring system groups. Now, in terms of warnings and precautions, first one being myelosuppression. As one can imagine, fatal and serious myelosuppression and infectious complications can occur with this medication. Obtain complete blood cell count prior to the initiation of treatment, prior to each cycle, and as clinically indicated to monitor for response and toxicity. Delay the next cycle and resume at the same or reduced dose as recommended. The next being embryo-fetal toxicity. This can cause fetal harm. Advise patients of the potential risk to a fetus and use of effective contraception. And lastly, drugs metabolized by cytidine deaminase. It is recommended to avoid co-administration within COVID. The dosage is 1 tablet taken orally once daily on days 1 through 5 of each 28-day cycle. In terms of availability, it is found in a tablet formulation of 35 milligrams of decitabine and 100 milligrams of sidazardine. In terms of this medications for special populations, safety and efficacy has not been studied in pediatric patients, and there's no dosage adjustment required in mild to moderate hepatic impairment, and it has not been studied in severe hepatic or renal impairment. On the next slide, we have Iclusig. In December 2020, the FDA approved a new indication for the treatment of adults with chronic phase chronic myeloid leukemia with resistance or intolerance to 2 or more prior kinase inhibitors. As you can see, there are other indications here. This medication does have a black box warning along with other warnings and precautions. However, this is not all. These are not new and therefore are not highlighted here. The dosage for this new indication is 45 milligrams orally once daily, with a reduction to 15 milligrams once daily upon achievement of less than or equal to 1% BCR ABL1-IS. In terms of special populations, no safety or efficacy has been established in pediatric patients. Again, no dosage adjustment required in mild to moderate renal impaired patients, and not studied in severe. In terms of hepatic impairment, there is dosage adjustment for patients with child Pew score A, B as in beta, or C as in Charlie. On the next and final slide for this subclass, we have Euconic. In February 2021, the FDA granted accelerated approval to Euconic, a kinase inhibitor, for the treatment of adults with relapsed or refractory marginal zone lymphoma who have received 1 or more prior anti-CD20 based regimen, or relapsed or refractory follicular lymphoma who have received 3 or more prior lines of systemic therapy. The indications are approved under an accelerated approval based on overall response rate. Continued approval for these indications may be contingent upon verification and description of clinical benefit in a confirmatory trial. In terms of warnings and precautions, infections being the first, it is important for clinicians to monitor for fever and any new or worsening signs and symptoms of infection, evaluate promptly and treat as needed. Neutropenia, monitor blood counts during treatment. Diarrhea and non-infectious colitis, and lastly, hepatotoxicity, which requires monitoring LFTs and hepatic function. The recommended dosage is 800 milligrams daily, and it is very important to manage toxicity using treatment interruption, dose reduction, or even discontinuation. And it is available in 200 milligram tablets. I'll go ahead and pause right there. We'll pivot over to oncology oral breast. I did want to ask the committee if they have any questions. I can pause under each subclass instead of waiting until the end.
This is Ginny. Thanks, Umang, for offering that. Committee members, do you have any preference? I guess we'll just keep going, Umang.
Okay, no problem.
Thank you for pausing.
No, that's okay. It selfishly gave me a chance to get some water too, so thank you.
That's needed. I think so.
Yeah. Okay, the next being breast cancer. On the next slide here. Breast cancer is the most common site of cancer for women in the United States, accounting for 30% of all cancer diagnosis, and is second only to lung cancer as a cause of cancer death in American women. It is estimated that there will be 281,000 new cases of breast cancer diagnosed in the U.S. in 2021, and there will be an estimated 43,000 deaths. The incidence of breast cancer in U.S. women continues to increase by about 0.5% a year. Known risk factors that may be contributing to this increased incidence include a decline of infertility rates and an increase in body weight. Despite this increasing incidence, death rates from breast cancer have declined by 41% since 1989, largely due to improvements in both early detection and treatment. The overall 5-year survival for women diagnosed with breast cancer is 90%. Patients who present with localized disease have a 98.9% 5-year survival rate. However, prognosis for patients presenting with distant metastatic disease is much poorer, with a 5-year survival rate of only 28.1%. Breast cancer is most frequently diagnosed in women between ages 55 to 64, with a median age at diagnosis being 62 years. Rarely, breast cancer may be diagnosed in men. Other risk factors include various endocrine, genetic, environmental, and lifestyle factors. And some of these risk factors are modifiable, some are not, and the impact of these factors are variable. On the next slide here, we'll pivot over to the guidelines. In terms of neoadjuvant treatment of breast cancer, historically, the role for neoadjuvant chemotherapy was limited to breast cancer patients with inoperable, locally advanced disease, but contemporary breast cancer treatment protocols now often include neoadjuvant therapy. There are several reasons for this expanded role of neoadjuvant therapy. First, it can increase the likelihood of patients being able to undergo breast-conserving surgery. Second, studies have shown that patients with triple-negative breast cancer and those with a HER2-positive disease who achieve a pathologic complete response, defined as the absence of invasive disease in the breast and lymph nodes following neoadjuvant therapy, have an improved prognosis. And recently published research has focused on response to neoadjuvant treatment as a predictive marker and a guide for selecting subsequent adjuvant therapy. In terms of the ASCO guidelines this year, regarding neoadjuvant chemotherapy, endocrine therapy, and targeted therapy, the guidelines recommend neoadjuvant therapy with any of these modalities if the patient has inflammatory breast cancer or if the patient has unresectable or locally advanced disease at presentation, such that the disease may be rendered resectable with neoadjuvant treatment. Furthermore, the guidelines state neoadjuvant systemic therapy should be offered to patients with a high-risk TNBC in whom the finding of residual disease at the time of surgery would guide recommendations related to adjuvant therapy. Regarding neoadjuvant endocrine therapy, the guidelines state that postmenopausal patients with an HR positive or HER2 negative disease may receive a neoadjuvant aromatase inhibitor to increase local regional treatment options, or if there's no intent for surgery, endocrine therapy may be used for disease control. However, for premenopausal women, patients with a HR positive HER2 negative early stage diseases, neoadjuvant endocrine therapy should not be routinely offered outside of a clinical trial. Okay. On the next slide here, according to the American Society of Hematology last year, they published guidelines. My apologies. Please skip this slide. This actually had to go back with the previous slides. On the next slide here, we have the subclasses. So as you can see, here's an overview of all the subclasses for the Apple Health Organization. They consist of anti-neoplastics, miscellaneous combinations, which include Kisqali and Humira. We have cyclin-dependent kinase inhibitors, Ibrance, Kisqali, and Verzenio. We have polymerase inhibitors, such as Talzenna. And we have, again, TKIs, such as Lapatinib, Nerlynx, Tukisa, and Tykerb. And again, we have 2 medications here with relevant recent significant recent clinical information. The first on the next slide being Nerlynx. In August 2020, FDA approved for use in combination with capecitabine for the treatment of adult patients with advanced or metastatic HER2-positive breast cancer who have received 2 or more prior anti-HER2-based regimens in the metastatic setting, already indicated as a single agent for the extended adjuvant treatment of adult patients with early-stage HER2-positive breast cancer to follow adjuvant trastuzumab-based therapy. Again, this is an expanded indication, so no changes in the warnings or availability. And as you can imagine, due to different indications, the dosing is stratified by indication. In terms of special population for this medication, safety and efficacy is not established in pediatric patients, and there's no dose adjustment required in mild to moderate renal impairment, but there is a dose adjustment required for severe hepatic impairment. Excuse me. On the next and final slide, we have Talzenna. In October 2020, FDA approved this medication for the use in patients with severe renal impairment, defined as a creatinine clearance of 15 to 29 milliliters per minute. Just so one knows, the indications for this medication are treatment of adult patients with deleterious or suspected deleterious germline BRCA mutated, HER2 negative, locally advanced or metastatic breast cancer. Select patients for therapy based on FDA approved companion diagnostic for Talzenna. No other changes. It is expanded to, as I mentioned, severely renally impaired patients. No changes to dosage or availability. and I'll pause right there. We'll be going on to renal cell carcinoma, but I'll see if anyone has any questions.
Yeah, hi, this is Susan. So back on your slide where you listed the various drug classes, you have the talzaparib under PARP inhibitors, but I believe olaparib is also a PARP inhibitor has the same indication that the Talzenna does, for metastatic BRCA mutated breast cancer. So shouldn't olaparib or Lynparza also be in that category under PARP inhibitors?
This is Umang. I am, if you give me 1 second, I'm just looking that up right now.
Okay. I wasn't sure if this was just because it was a newer agent out that you didn't include the other one, but yeah, anyway.
I can, and I believe Marissa may have stepped away. I think I saw a message, but I may need to confer with Marissa about this because I believe I pulled these from the specific Apple Health PDL.
Okay.
I can circle back and once I get a chance to look in there to see if I do see Lynparza listed on there, but I don't believe I did when I was creating these slides.
Hey, Umang. This is Marissa. I'm back.
Hey, Marissa.
Yeah, so Lynparza is included in the PARP inhibitors drug class. So we have Zejula, Lynparza, Rubraca, and Talzenna all in that inhibitors class.
Okay, then you are correct. It should be listed here. However, it wouldn't be bolded or reviewed as there was no significant information for that medication for, I believe, at least 3 years.
Okay, sounds good. Thank you.
Thank you. Okay, this is Umang again. Hearing no other questions, I'll continue onward to renal cell carcinoma. On the next slide, cancers of the kidney and renal pelvis account for approximately 4% of all newly diagnosed cancers in the United States, with a 5% incidence in males and 3% in females. The median age of diagnosis is 64 years, and over 75% of cases are diagnosed in patients 55 years of age or older. The overall 5-year survival for patients diagnosed with renal cell carcinoma was about 76% from the period of 2011 to 2017. If the disease is localized at the time of diagnosis, outcomes are excellent with a 5-year survival of approximately 93%. However, patients diagnosed with advanced metastatic disease, accounting for approximately 16% of diagnoses, have much poorer outcomes with approximately a 14% survival rate at 5 years. About 85% of kidney tumors are renal cell carcinoma, and approximately 70% of all renal cell carcinoma have a clear cell histology. Other less common histologies are usually grouped together as non-clear cell tumors. The incidence of renal cell carcinoma in men is more than twice than that of women in the US. The most common presenting triad of symptoms include hematuria, flank mass, and flank pain. However, as the use of routine imaging has become more widespread, the frequency of incidental detection of RCC has increased, and only about 30% of patients are now diagnosed on the basis of symptoms. On the next slide, we did have new guidelines this year from the NCCN. For first-line systemic therapy of favorable risk, clear cell histology, relapsed or stage 4 renal cell carcinoma, the guidelines recommended TKI plus an immune checkpoint inhibitor as a category 1 preferred option. Specifically, I apologize if I'm saying this incorrectly, Inlyta plus Keytruda or Cabometyx plus Opdivo or Lenvima plus pembrolizumab are the 3 TKI CPI regimens included. Other recommended regimens for the same group of patients include monotherapy with Sutent, Votrient, or Inlyta plus avelumab. Axitinib monotherapy is an NCCN Category 2B recommendation listed as useful in certain circumstances. For the same group of patients with poor or intermediate risk rather than favorable risk, the same 3 TKI CPI regimens are listed as Category 1 preferred, along with single agent cabozantinib being a Category 2A preferred option. Other options for these patients with poor or intermediate risk largely mirror the favorable risk options defined above. For subsequent therapy of RCC with clear cell histology, Category 1 preferred options include cabozantinib and levatinib plus Afinitor. Additional options include axitinib as either a single agent defined as a Category 1 or in combination with pembrolizumab, Category 2A. Cabozantinib plus nivolumab, lenvatinib plus pembrolizumab, or single agent pazopanib, sunitinib, or tivozanib. Everolimus as a single agent is included as a Category 2A, useful in certain circumstances. For patients with non-clear cell histology, single agent cabozantinib, sunitinib, axitinib, pazopanib, and everolimus are all Category 2A recommendations, though cabozantinib and sunitinib are the preferred regimens. Importantly, sorafenib is now only indicated in the NCCN guidelines as a Category 3 recommendation for subsequent therapy that may be useful in certain circumstances. Now, on the next slide here, we have the subclasses here broken down into the mTOR kinase inhibitors, the multi-kinase inhibitors, and the TKIs. For the mTOR kinase inhibitors, we have Afinitor and everolimus. Oh, there we go. Thanks, Lita. Then we have for the multi-kinase inhibitors, we have Fotvita, Inexavir, and Sutent. And then for the TKIs, we have Cabometyx, Inlyta, Lenvima, and Votrient. And so we'll move on to the first of the 3 medications that were bolded there, Inlyta. First of the 4 medications, excuse me. In June 2020, there was a new indication in combination with avelumab or pembrolizumab for the first-line treatment of patients with advanced renal cell carcinoma, previously approved as a single agent for the treatment of advanced renal cell carcinoma after failure of 1 prior systemic therapy. And as a single agent, I apologize. As you can see, they already had a list of other indications. There are no updates to the warnings and precautions of their cardiac failure, hypertension, and hypertensive crisis, VTEs, or embryo fetal toxicity. The dosage for this medication is stratified by indication, and the availabilities are unchanged as well by this expanded indication. There's no safety or efficacy data for pediatric patients, and no studies are conducted for renally impaired patients. For patients who do have moderate hepatic impairment, there is a dose adjustment that is recommended for this medication. On the next slide, we have Fotivda. In March 2021, FDA approved this medication for the treatment of adults with relapsed or refractory advanced renal cell carcinoma following 2 or more prior systemic therapies. The warnings and precautions are very similar with cardiac failure, hypertension, hypertensive crisis, VTEs, and embryo-fetal toxicity. The recommended dose here being 1.34 milligrams once daily with or without food for 21 days on treatment, followed by 7 days off treatment. And this is a 28-day cycle until disease progression or unacceptable toxicity. It is available in capsule form, being 1.34 milligrams or 0.89 milligrams. Similar to the previous medications, safety and efficacy has not been established in pediatric patients. There's no dosage adjustment needed in renally impaired. And if a patient has hepatic impairment, it is recommended to adjust the dosage in patients with moderate hepatic impairment and to avoid in patients with severe hepatic impairment. On the next slide here, in terms of a new generic, sorafenib, in September 2020, the FDA approved sorafenib by Mylan as the first AB rated generic for Nexavar. And in terms of Cabometyx or Opdivo, in January 2021, FDA approved expanded indication for Cabometyx and Opdivo for use in combination for first-line treatment of patients with advanced renal cell carcinoma. On the next slide, we'll pivot over to skin cancer. I'll pause there for any questions. Okay, this is Umang. Hearing none, I'll continue onward to skin cancer. On the next slide, thanks, Leah. We have an overview of the subclasses by Apple Health Organization. For what we define as skin cancer, this includes the BRAF kinase inhibitors, such as Braftovi, Tifinlar, Zelboraf. We also have the hedgehog pathway inhibitors, which is Araveg and Odomzo. And lastly, the MEK inhibitors, which is Cotellic, Mekinist, and Mektovi. In this class with these 3 subclasses, there were no significant clinical updates within the last year in this class. So we'll pivot right over to the next cancer class, which is lung cancer. Again, pause there for any questions for skin cancer. Okay, this is Umang, continuing onward. On the next slide, we have a little bit of an overview. So lung cancer is the leading cause of cancer death in both men and women in the US. In 2021, an estimated 235,000 new cases of lung cancer will be diagnosed, and 131,000 deaths are estimated to occur. Currently, the 5-year survival is estimated to be 21%, an increase from 18%. Excuse me. I apologize. Declines in lung cancer mortality in the US have been accelerating in recent years. From 2009 through 2013, lung cancer mortality declined 2.4%. But from 2014 through 2018, this decline more than doubled, resulting in a 5% decline. Additionally, there have been a steady decline in the incidence of lung cancer diagnoses in the US. The number of diagnoses declined 2.3% in the most recent measurement. And despite these encouraging trends, there are still more US lung cancer deaths annually than deaths from breast, prostate, and colorectal cancer combined. The primary risk factor for the development of lung cancer is smoking tobacco, accounting for approximately 85 to 90% of all cases of lung cancer. The carcinogenic chemicals in cigarette smoke are responsible for most lung cancer-related deaths, while exposure to secondhand smoke also results in an increased relative risk of developing lung cancer. While chemoprevention agents are not yet established, lung cancer screening using low-dose computerized tomography is recommended by the U.S. Preventative Services Task Force, who expanded their lung cancer screening guidelines in 2021. The guidelines now recommend annual screening for patients 50 to 80 years of age who are current smokers with at least a 20-pack year smoking history and former smokers who have quit within the past 15 years. On the next slide. In terms of guidelines, so EGFR sensitizing mutations, the guidelines have been updated to incorporate the use of Tagrisso in adjuvant setting of earlier staged non-small cell lung cancer. The guidelines recommend the use of Tagrisso for patients with stage 2Bs and beta or 3As and alpha disease who have undergone complete resection, or for patients with high-risk stage 1Bs and beta to 2As and alpha EGFR mutation-positive disease who received previous adjuvant chemotherapy or are ineligible to receive platinum-based chemotherapy. This year, the ASCO and the Ontario Health Cancer Care Ontario guidelines stated regarding stage 4 non-small cell lung cancer with driver mutations, they indicate that osimertinib should be offered in the first-line setting for patients with the following mutations: T790M as in Mary, L858R, or exon 19 deletion EGFR mutations. If osimertinib is not available in the first-line setting, gefitinib with chemotherapy or dacomitinib may be offered. Other options listed by the guidelines include afatinib or erlotinib and bevacizumab, erlotinib and ramucirumab, or gefitinib, erlotinib, or icotinib, not available in the US as single agents. In terms of BRAF V600E point mutations, for patients with advanced metastatic lung cancer who are found to have BRAF V600E mutations, a combination of dabrafenib, which is Tafinlar, plus Mekinist is recommended as preferred line